ऐ दर्द बता कुछ तू ही पता।
I am a widow of Professor Samashera. It's my pleasure to talk about my husband. We've been married for 54 years. He's been a marvelous husband. We have 3 lovely daughters, highly educated and happily married. We have, mashallah, 8 grandchildren. Samad was very fond of each and every child, and they also loved their grandfather.
May Allah place his soul in heaven. He was pioneer of diabetes in Pakistan long ago, and he introduced Pakistan at international level, including IDF, mainly IDF. He was always very helpful, always smiling, always guiding. We were quite junior to him. We learned a lot from him, and he was pioneer for IDF Mena region and DASC, Diabetic Asia Study Group. He was pioneer actually.
A legend, my mentor. I was introduced to him 30 years back when it was the World Diabetes Conference in Karachi in 1990. And I have no words to thank to him for having introduced me in the world of diabetes, both nationally and internationally. He was a man of principle, perfectionist, a man of dot and comma, as he used to.
I am associated with IDF since 1982, and likewise I am very, very happy that as Pakistan belongs to the MENA region has progressed well.
I worked with him for last 24 years. He was a great mentor, mentored me throughout my clinical practice over this long period. He was a true leader and used to lead the team from the front. He was a perfectionist and liked perfectionism. He was dedicated to the cause for diabetes and would like and enjoy working with those who are dedicated for the cause.
मरहूम किसी के तारीफ़ के मोहताज नहीं थे, न उन्होंने अपनी ज़िंदगी में इसकी फ़िक्र की कि कौन उनके लिए क्या कहता है। और यही उनकी एक ख़ास बात थी कि वो अपना काम करते थे, कभी उनके मुंह से ये नहीं सुना कि लोग क्या कहते हैं। और ये ऐसी खूबी है जो बहुत कम लोगों में पाई जाती है। लेकिन जो मैं ज़्यादा मुतासिर हुआ जिस चीज़ से, वो समझ साहब का हाफ़िज़ा।
लाखों ही मुसाफिर चलते हैं, मंजिल पे पहुंचते हैं, 2-1 लाखों ही।
डाइटिंग खेल नहीं चंद दिनों का बेगम, एक सदी चाहिए कमरे को कमर होने।
The Diabetic Association of Pakistan was established in 1966. This place is a WHO collaborating center since 1991. One in 37 countries. It is very bright because we had developed a team.
Hello, everybody. So, on this auspicious day of Insulin Centenary webinar, I will first start the program with a tribute to the legend. We already had watched the video. So, Professor Abdul Samad Shera, I would like to say a few words to pay tribute to him. Professor Abdul Samad Shera was born in 1935 in Alwar, British India, and he migrated to Pakistan when he was 11 years of age. And after his post-graduation from UK, he came to Pakistan and practiced as physician and diabetologist since 1960 till the last day of his death. He continued practicing medicine. So Dr. Samad Shera was a General Secretary of Diabetic Association of Pakistan for 45 years. And he was the honorary president of IDF and also the head of the World Health Organization Collaborating Center for Treatment, Education, Research in Diabetes and Diabetic Pregnancies. He was also the chair of IDF Mena region for Diabetes Guideline Committee. So Dr. Professor Samad Shera, he was also the first president of DAS, that is Diabetes in Asia Study Group, and was also a national coordinator for diabetes prevention and control program. In recognition of his services in the field of diabetes and medicine, the President of Islamic Republic of Pakistan has conferred on Professor A. Samad Shera the prestigious civil awards of Sitara Imtiaz and Tamga Imtiaz. And this is not the last but the least, Professor Noorjahan Samad, wife of legendary Professor Samad Shera, she said that Samad is everywhere, but where is he? So my answer to Madam, who is also my teacher, is that Professor Samad Shera is dwelling deep in our hearts and will continue to be in our memories for the years to come. Thank you, Professor Shera, for all your services and contributions to the cause of diabetes. So after this, I'll come to the program. So I welcome you all in this Insulin Centenary webinar. The theme of the year, as we all know, is that nurses make the difference. As very rightly said, many decades back, by the father of obstetrics, Dr. Ian Donnell, that give me a pair of outlet forceps and 2 midwives, and I can run the whole obstetric unit. So right he was. But by not including or partially including the nurses in healthcare system in most countries of the MENA region, we provide fragmented care to our patients. Nurses are considered as backbone of our healthcare system. So how can we expect the spineless health system to work efficiently if we do not consider nurse training and their share in deliverance of healthcare? So I welcome doctors and nurses and non-nurses in this program. And to start with, I will request Professor Jamal Belkhadir for his welcome note. Professor Jamal Belkhadir is the chairman of IDF MENA region. He was the professor, Department of Internal Medicine at University of Rabat. He is the vice president of American Francophone Society of Diabetology and also the vice president of African Society of Diabetology, Metabolism and Nutrition, and president of Moroccan League for the Fight Against Diabetes. So I'll request Professor Jamal Belkhadir for his welcome note. Professor Jamal.
Thank you a lot, dear Shabin. Hello, everyone, dear friends and colleagues. As chair of IDF MENA region, it's really deep pleasure and honor for me to give short talk with our president of IDF, Professor Andrew Bolton, and IDF Vice President, Professor Hussein Akhtar, at the beginning of our 50 IDF MENA Blue Circle webinar. First of all, I want to express my deep thanks to Professor Shabin the coordinator of IDF Mena Working Group of Insulin Centenary, and Professor Hassani, the coordinator of Scientific Committee of IDF Mena Blue Circle webinar. They have prepared with the members of their active group many activities, and particularly this webinar, which bring us together. I am convinced that the rich program of the webinar, which will be animated by experts of MENA region and outside, will please you and will meet your expectations. As you know, this year, with the celebration of the Insulin Centenary, World Diabetes Day coincides with the International Year of the Nurse and the Midwife. The theme of World Diabetes Day 2020 is the nurse and diabetes. The campaign slogan for this year is Nurses Make the Difference for Diabetes, that highlights the crucial role of nurses in supporting people living with diabetes. This webinar, which is a part of the Insulin Centenary and the celebration of the World Diabetes Day, pays tribute to nurses. The Eastern Mediterranean region has the highest rates of diabetes worldwide, with more than 43 million people living with diabetes. Overweight and obesity are the strongest risk factor for type 2 diabetes and account for the 90% of diabetes cases. Diabetes increases the risk of heart disease and stroke, and this is leading cause of blindness, lower limb amputation, and kidney failure. People living with diabetes are more likely to experience catastrophic personal health expenditure. In addition, COVID-19 pandemic has taught us how much vulnerable our systems are in terms of preparedness, and creates challenge in the provision of care for patients with diabetes. Furthermore, while nursing leadership in policy and advocacy is imperative to change practice and expand the nursing capacity to address diabetes, nursing leaders are underrepresented in the diabetes movement in Eastern Mediterranean region. The promotion of broader understanding of nursing work is essential in order to increase visibility and recognition of the profession. It's essential that nurses and their organizations take on this leadership role in even stronger way, working with decision makers to achieve positive health outcomes and provide an effective quality of care at lower cost. As IDF MENA region, we have developed this year partnership with WHO, EMRO, and the International Council of Nurses in celebrating the World Diabetes Day. The collaboration with our partner on the World Diabetes Day will lead to longer-term collaboration with new initiative to strengthen roles of nurses in improving the health and well-being to diabetic people and save their life in our region. This webinar today and others will provide a forum to discuss strategies to maximize the utilization of nurse and midwives' capacities in maintaining essential health services, including non-communicable disease in member states, and confronting diabetes as critical global health issue, and initiating further joint activities to take the World Diabetes Day agenda forward. Dear friends and colleagues, the celebration of the World Diabetes Day and the Insulin Centenary give us the opportunity to thank the nurses in MENA region and to express our support so that the role in the care of diabetes is better recognized and defended. Thank you for your attention.
Thank you, Professor Jamal. Now I have the privilege to introduce Professor Andrew Bolton. And Professor Bolton, I do not know where to start and where to end. So, but to and in fact, you do not need any introduction, but to say a few words about you, Professor Bolton is a graduate of Newcastle upon Tyne and subsequently trained in Sheffield and Miami prior to accepting the appointment of Manchester University. Dr. Andrew Bolton, he's currently the senior associate editor of Diabetes Care, and in 2019 he was ranked #1 UK diabetes researcher in the field of complications. He was the founding chairman of the Diabetic Food Study Group and currently is the president International Diabetes Federation and chairman of European Alliance for Diabetes Research. As far as awards are concerned, he received ADA's Roger Picorera Lectureship Award, the ESD Camilla Golgi Prize, and he was the first recipient of the International Award on Diabetes Food Research. He was the 2008 winner of ADA's Harold Rifkin Award for Distinguished International Services in Diabetes. He received the 2012 Georgetown Distinguished Achievement Award in Diabetic Limb Salvage and Endocrinology Award from American Association of Endocrinology. So after all these awards, Professor Andrew Bolton, please accept one more award from myself and from Professor Akhtar Ahmed. We awarded you as an Ironman for your untiring efforts towards the cause of diabetes. And in the end, I am surprised and I am very delighted to say that he has authored 550 peer-reviewed manuscripts and book chapters on diabetic lower limb and complications. So to you, Professor Andrew Bolton, for your inaugural talk on insulin centenary.
Shukriya, Shabin. Good afternoon to many friends, all my friends in the region. Bonjour, tous les pays francophones, Maroc, Tunis, Algérie, Liban. Il y a 20 ans, j'ai parlé beaucoup de français, mais you'll be glad to hear I'm going to speak in English because my Arabic's very weak. So I will try and share my screen, and it's a pleasure to be with you today. Okay, yes. So it's a pleasure to be with you, and it was an honor to be a friend of Samad Shera for many years. I first met him probably 30 years ago, and he was a mentor to all of us, most of the previous presidents of IDF, and it was a great honor to be counted as a friend of Samad Shera, who did so much for diabetes in your region. So, as you know, November the 14th officially is World Diabetes Day because this is the birth of Frederick Banting, one of the discoverers of insulin in Toronto in 1921. But I think it's more important to think of World Diabetes Month or the World Diabetes Year. And as you know, World Diabetes Day was started by the IDF about 30 years ago. This is the 30th one, and it was adopted by the United Nations in 2006-07, and by a resolution that this is recognized as a very critical disease and that World Diabetes Day would hereafter take place. And of course, IDF is across 160 nations with hundreds of member associations across the world. This year, we've dedicated it to the Year of the Nurse, and my friend Akhtar Hussain, President-elect, will follow me and talk more about the Year of the Nurse. But the theme is Nurses Make a Difference, as you've heard, and as you will hear in more detail. I'll just tell you one story from Professor Harry Keane, who I know knew Samad Shera very well. Harry Keane was a pioneering diabetologist in the UK. And he said in one lecture about 10, 15 years ago, that the most important discovery of the 21st century was home blood glucose monitoring, or the 20th century, I should say, 20th century. But the next most important thing was the diabetes specialist nurse, and that's how much he valued nurses. Now, I hope you will share your World Diabetes Day, and it fell on a Saturday this year, so celebrations are occurring before and after, as you are today. There are many activities, and we have many activities at IDF, and you can share this and see it on all these different social media. Now, if we look forward, Of course, 1921 was a pioneering year, and it was Frederick Banting, who I've already mentioned, together with MacLeod, Charles Best, who was a medical student. I always teach my medical students, I said, there's hope for you, because Charles Best, co-discoverer of insulin, did this when he was a student on a project. And of course, Collett, the biochemist. So we're celebrating 100 years, but we want to advocate change as well. And here is the history. Banting gets the research idea. He was actually trained as an orthopedic surgeon. So he saw the light and came to diabetes, you see. He met MacLeod, professor of physiology there, originally from Aberdeen in Scotland, started the experiments and working with Charles Best, and as I said later with Collett, the biochemist. This is the scientific history of the discovery of insulin. But we'll be talking much more about that next year. But we just don't want to talk about the celebration of the discovery, but let's talk about access to insulin across the world. Nobody anywhere in the world should be denied access to insulin. So we place World Diabetes Day 2021 and the centenary celebrations under a broader multi-year program dedicated to access, to promote access not only to insulin, but all other diabetes medicines, technologies, and education that ensure affordable and quality management for diabetes and its complications. So I thank you very much. Merci bien, shukran, for all your attention. I wish you a very happy World Diabetes Month and a very successful meeting this afternoon. Thank you.
Thank you, Professor Bolton, for your very nice brief talk. And I'm very, very thankful on behalf of Insulin Centenary Working Group that in spite of your very, very busy schedule, you managed to join us. And that's a great privilege and pleasure for us. Thank you very much. And thanks for that shukran thing. We liked it. So the next speaker with us is Professor Akhtar Hussain. Professor Akhtar Hussain, I again don't know where to start and where to end. He has lots of contribution in the field of diabetes. But to start with, I must introduce Dr. Professor Akhtar Hussain as he's originating from Bangladesh and educated from USA and Norway, and is a diabetologist and epidemiologist by training. He is the professor of medicine in Nord University, Norway, and he is presently the president-elect of International Diabetes Federation. He was president-elect in Busan in 2019. Previously, he was vice president of IDF. He is presently the president of Diabetes in Asia Study Group and also a co-editor of the Journal of Diabetology and official journal of DAS. So he is a co-chair and professor of Center for Global Health, Bangladesh Diabetes Association and Bangladesh University of Health Sciences. And he also has published more than 150 articles in peer-reviewed journals. And the important thing is that he has supervised 14 PhD students and 50 master students. So over to you, Professor Akhtar Hussain, and he'll be delivering the most important part of today's lecture, today's talk, and that is the role of nurses in diabetes in Mena region. Professor Akhtar.
So thank you, Dr. Shabin and Professor Shabin, and I'm really thankful to all the organizers and my friends, Jamal Dulkadij, Professor Shabin, Zaman Sheikh, Adil Said. Salam alaikum. And it's a great pleasure for me to be with you today. I will start with that Andrew has already talked about that it was actually World Diabetes Day. We started in 1991. IDF started this celebrating the World Diabetes Day on the 14th of November in 1991 with the support of the WHO. And then comes that this UN resolution that passed in 2006. It was under the leadership of Professor Martin Schilling. At that time, he was the president of the IDF. This proposal was proposed to the UN by Bangladesh UN ambassador, and this has been accepted. So this is the little bit of the story of how we get it. And actually, this is one of the, I think this is the only non-communicable disease which has been recognized by the UN as a one day, because we have some such days for infectious disease, but not with non-communicable disease. We have to think that what is the purpose? What is the purpose of this World Diabetes Day? It is to actually maximize the awareness of a condition that millions of people globally is live with some people with control and many with complications. And this is the fact that we must embrace before we come to the nurses and this part. You see that what we are doing, there is a growing number, around 500 million people around the world is having diabetes. This is one thing. And 4 out of these 5 live in poor or in the developing countries. And actually 4 out of these 5 in the developing countries are actually under the age of 65. So therefore, diabetes should not be considered only a disease. It is a developmental issue. Unless the developing nation can control diabetes, we will not have development. If you look at the MENA region, you have the highest prevalence of diabetes, not in terms of numbers, because numbers as China will of course come up as the first, but in terms of prevalences, the MENA region has the highest prevalence of diabetes. As we have seen that I've mentioned that Professor Abdul Basit, he has already published a paper from Pakistan where actually the prevalence rate was about 30%. 1 in every 3 adult person have diabetes. So this is the situation that we are tackling, and this is the time, this is the point of time we are celebrating the World Diabetes Day. So how does nurses, we said that when the nurses make the differences, how the nurses make the differences, because they should be considered as an important member of the diabetes team. And in the teamwork, what I think that in a teamwork, everyone should be respected for the work they do. And the work should be laid out, that not that everyone is doing everything. That creates simply confusions. For example, nurses are particularly known for example, promoting, for example, patient education. The patient education is, we know that education is the treatment for diabetes. And this is, the nurses can do it much more effectively because we don't have time, the doctors. They can also do the monitoring, that how the glucose is being monitored, whether it's a CGM or it's on a, so you have to, they should be monitoring this diabetes. And they should be, the most important thing, they are a kind of link between the patient and the doctor. And this role is very important, that the nurse is the advocate for the patient, is the patient advocacy. So we have to understand that the world is different, the cultures are different, the health structures are different. Given this structure, we have to understand that these roles can be defined according to the need, according to the qualifications, because the nurses' qualifications or training are also very different in different countries. So given the situation, so we have to see that how, but whatever the roles are, it should be defined in as a member of the team and should be respected. And we know that this is a largely unused resource that we have in our community. These things we have to change. I remember that when I was a medical student, that the nurse's role, we never thought about it. But for example, when I come to Europe, then we say that this is a completely different. But if you look even within Europe, you see the role of the diabetes nurses are also very different. It's not the same. So we need to think that it's not that everyone should be following the same guidelines. Everyone should see their own structure, their qualifications of the nurses training, and need, and also the health system, that how this health system is built up, and should be placed as an important member. This is important that we bring them as an important member of the team and should be respected accordingly. And this is, and at that end, in the inauguration, I like to mention the challenges that we are facing. Now we are facing at a time of COVID-19. COVID-19 is posing a great challenge for diabetes, because we know that now the newer studies are showing that this virus can get into the cells and actually it can destroy the beta cells. That means that you are creating new a wave of people with diabetes, and this has shown to introduce both type 1 and type 2. So we are going to this 500, the projection that we are talking about, this is going to increase. It has also caused, we know that the mortality rate for people with diabetes is about 3 times more compared to the people without diabetes. And the most important thing that, for example, the international community will soon be tempted to lose focus on non-communicable diseases rather than focusing on the infectious diseases. The fact is that we must keep our advocacy for the non-communicable diseases and diabetes in particular, so that we do not lose focus on the important thing, because without controlling the diabetes, we will not be able to control the COVID-19. And this important information the policymakers should know. At the end, I would also like to give my deep respect to the memory of Professor Samad Shera, who has been a mentor for me for a long time. First time I said that I met him in 1998 in Sri Lanka. So it's about 22 years of that we know each other. He was a brother to me. We have always collaborated very closely. He has invited me many times to Pakistan in his beautiful home. And I also had the opportunity to invite him to Norway on several occasions. So we supported each other, and he has always supported me, and I will always remember him and miss him very much. So with this word, I wish you all the very success for this very important occasion. Thank you.
Thank you, Professor Akhtar, for your very nice talk. And we wanted to listen more from you, but because you all are very busy, so we thought that let us have some introductory talk from you and listen to your views and your ideas about this insulin centenary and nursing, role of nursing. The last speaker of this inaugural session is Professor Mohammad Sandeep, and let me tell all the audience, all the participants who are with us, that this is a very important seminar, and please do not leave after inaugural session, because the scientific session and the panel discussion is to follow this inaugural talk. So I would like to invite Professor Mohammad Sandeep. Professor Sandeep is the president of Lebanese Diabetes Association, and presently he is the IDF Mena chair-elect, and is the founder and manager of National Diabetes Program, and he is also in the advisory board in National Diabetes Committee. Professor Sandeep has published more than 40 articles in peer-reviewed journal, and Professor Sandeep, we would be very delighted to listen to you. So over to you, Professor Sandeep, for importance of World Diabetes Day.
Dear Professor Bolton, Professor Akhtar, Professor Jamal, all speakers, moderators, organizers, and audience. World Diabetes Day was by the International Diabetes Federation and the World Health Organization almost 30 years ago, in response to growing concerns about the escalating worries caused by diabetes. This particular day was chosen to celebrate the birthday of Frederick Banting, who co-discovered insulin in 1922. World Diabetes Day is the world's diabetes awareness campaign, reaching a global audience of over 1 billion people in more than 160 countries. Every year, the World Diabetes Day campaign focuses on a dedicated team that runs for 1 year. The World Diabetes Day themes 2013, Protect Our Future Diabetes Education and Prevention. 14, Go Blue to Breakfast. 15, Healthy Eating. 16, Eyes on Diabetes. 17, Women in Diabetes. 18 and 19, the family and diabetes. This year, World Diabetes Day for global pandemic that already have taken the lives of so many people, and diabetic patients are paying a high price. That's why this year's topic will focus on the importance of nurses. Nurses are the link between the diabetic patient and all other healthcare givers, and they are excellent educators and must be an active member of the medical team. Nurses currently account for over half on the global health workforce. The common message for Diabetes Day or World Diabetes Day, diabetes is rising dramatically. Diabetes is a silent killer. Diabetes is harder to control in developing countries. Diabetes will undermine the economies worldwide. Diabetes can control, in many cases, prevented. So now I will show, in this slide, I will show you some picture of the World Diabetes Day celebration in some MENA countries. This is in Lebanon. This is in Qatar. I think this is in Gulf, in Lebanon also, in Oman. This is in Iran. This is in Gulf. And this is in Jordan. So due to the short time, I want to show more pictures that reflect the raising of World Diabetes Day activity in our MENA region. So in conclusion, World Diabetes Day is an important day to focus on diabetes awareness and education. During this celebration, we should collaborate with NGOs, societies related to the annual theme, media, government, to have a better impact in the wider audience. Celebrations should not take place during the World Diabetes Day or the month of November, but rather throughout the year with constant events to remind us about the importance of those topics. Workshops, training, webinar, conferences, etc., in this time of Corona. Let this day be a pure educational message and not be used in a commercial way. Finally, from the wounded Beirut, which will rise quickly, inshallah, from among the rubble, I wish you all health and safety and congratulations.
Thank you, Professor Sandeep, for your very nice talk and short and nice message. I'm again very, very thankful to all our August speakers of the inaugural session, Professor Andrew Bolton, Professor Akhtar Hussain, Professor Jamal is the host also with us, and Professor Sandeep for joining us in this Insulin Centenary program. And I'm also thankful to Insulin Centenary Working Group to organize this program. Can I request the organizers to please unmute for a while? Professor Dr. Abdul Basit wants to say a few words.
So I just wanted to say hello to my friends Andrew and Akhtar and Jamal and Sandeep and Shabin and Zaman. Already we meet every Wednesday anyway. Just want to thank you for what you are doing for IDF and for our region in particular. I must admit that we are overwhelmed by the support IDF is giving to IDF MENA region. You all are appreciating that we have lost our mentor for the region, Prof. Shera this year. We all are struggling to get Diabetic Association of Pakistan and the MENA region on its footing again. We are missing him a lot, but at the same time, our colleagues are working hard, and we are very grateful in person for all the support given by IDF, especially Andrew and Akhtar. Thank you.
Thank you, Professor Basit. Thank you very much for joining us. So now, after this inaugural session, I will hand over the floor to Nadima and to Dr. Nadima and to Michelle. Both of them will be conducting the scientific session. And may I request to play the video, which is shared by Dr. Jackie Malouf with us, but has a great emotional appeal for the nurses of the year, which is the theme of today.
موضوع اليوم العالمي للسكري لهالسنة بيسلط الضوء على أهمية دور الممرضين برعاية السكري.
بدي أشكر الممرضة سارة يلي ساعدتني اتخطى حاجز الخوف لما عملت أول إبرة أنسولين لبنتي نور.
أمي عندها السكري من النوع الثاني. شكر كتير كبير للممرض بول اللي ساعدني أهتم فيها بشكل أفضل.
ما بنسى أبداً الممرض يلي علمني كيف استعمل إبرة الأنسولين.
دورنا كأطباء بيتكامل مع دور الممرضين خاصة بحسن إدارة السكري.
وبتذكر دايماً الممرضة يلي علمتني أفحص السكر بالدم.
نعم، الممرضون يصنعون الفارق.
Hello everybody. Assalamu alaikum. It's my pleasure to welcome you all to the scientific part of our webinar, Insulin Centenary, on the occasion of World Diabetes Day, which I hope you find useful and interesting. Allow me to introduce my colleague in moderating this session, Dr. Michelle Abi Asad. She holds master's degree in public health. She is currently the administrator of the Chronic Care Center in Lebanon. She is also actively involved in the national campaign for diabetes and has several publications in this field. Dr. Michelle.
Thank you, Dr. Nadima, for your introduction. I have the pleasure to moderate with you this session. Actually, Dr. Nadima Sharm is a fellow of the American College of Endocrinology, a consultant in endocrinology and diabetes, president of the Jordanian Society of the Care of Diabetes, former vice president of the Jordanian Society of Endocrinology, Diabetes and Metabolism, head of the camp for children with diabetes, and published various scientific papers and experience texture. Dr. Nadima.
It is our pleasure now to introduce our distinguished speaker, Professor Adel Sayed. Professor Adel Sayed, Professor of Internal Medicine and Diabetes, WHO Diabetes Consultant, ex-chair MENA Region IDF, member of the IDF Global Board of Director, ex-president of Diabetes in Asia Study Group. He is the vice president of International Diabetes and Ramadan Ad-Dar Alliance Group. He is the founder and president of the Upper Egypt Diabetes Association. He is a member of several expertise committee and advisory board. He is going to talk today about 100 years of insulin. Professor Adel, the floor is yours.
Thank you very much indeed. I'm very grateful, Dr. Nadima, for the introduction. I'm grateful to Dr. Jamal and Dr. Sandid, the chair and chair-elect of our region, and to Dr. Shabin Masoud for inviting me to speak about the history of insulin discovery. I called it short story, insulin short story, because 15 minutes is not enough actually to give any significant part of the long and complicated story of discovery of insulin. And when Shabin asked me to speak about insulin discovery, I remembered an interesting story. 12 years ago, I have a friend from Syria called Dr. Muhammad Muhsin Saleh. Dr. Muhammad wrote a book about insulin discovery, and it was a big book actually, more than 500 pages. And after finishing it, he sent me the draft of the book just to write an introduction for the book. And I read everywhere that word actually the book, which was very well written in a high-level Arabic language. It's written in Arabic. A beautiful piece of Arabic literature, I have to say, and extremely interesting with detailed stories, full of suspense and attraction. I wrote 6-page introduction, and I kept the story in the back of my mind. So I'm always interested in that field actually, and I think we have to start with how diabetes was treated before the era of insulin. Before discovery of insulin, the diagnosis of diabetes meant a slow and miserable death sentence. And a number of bizarre methods were used to treat diabetes. One of the famous methods was the use of opium without any basis, just using insulin to treat diabetes, a practice which was difficult to stop until the discovery of insulin, in spite of the fact that they discovered that it is totally useless many years before stopping it. But it was a bad habit. In the late 19th and early 20th centuries, the beneficial effect of dieting, which was observed several decades before, started to being adopted by some physicians. The clear beneficial effect of dieting is the only intervention before insulin which led to clear benefit actually in some patients, of course, not every patient, but it led some physicians to be too enthusiastic to putting their patients on a strict diet. And here it's Alan Frederick. Alan Frederick was a famous American physician who applied very strict dieting down to 400 calories per day on his patients with extreme cruelty. Even for those who came to him with very debilitated because of the effect of diabetes. Actually, he knew, and he indeed confessed, that some of his patients died from starvation. And he paradoxically wrote in his diary in 1916 a comment on a young lady who died because of starvation, and he knew that. He said the diabetes was very severe, so much so it had led to the death of the patient who could not tolerate the dieting necessary for her life. Can you see the paradox in this sentence? In another comment, he comfortably noted our comparative observations between patients who died because of starvation and those who neglected dieting and died before diabetes because of diabetes showed that those who died due to starvation suffered significantly less. That's everything we can offer to those miserable people. So let's be back to the story of insulin. In the year 1869, an MD thesis was presented by a German student called Paul Langerhans. Of course, all of us know the name. In Berlin, under the title "Articles about Microscopic Anatomy of Pancreas." It contained the first description of islets of cells in the pancreas, which are different from the surrounding pancreatic tissues. Langerhans did not know the function of these cells, and later he died in the year 1888 at the age of 40-year-old, actually, because of pulmonary tuberculosis, without knowing the honor which he achieved by discovering these extremely important cells. Just 1 year after his death, von Mering and Oskar Minkowski were busy studying the digestive properties of the pancreas when they resected the pancreas of a dog. And to their astonishment, the dog developed diabetes. This experiment had proved an extremely important fact that in absence of pancreas, diabetes will inevitably develop. So it was hypothesized that the pancreas secretes a substance that controls carbohydrate metabolism. And in the first year of the 20th century, an American scientist called Eugene Opie discovered the missed relationship between diabetes and the mysterious cells of the islets of Langerhans, which are the beta cells, of course. For years, of course, everybody wanted to make extract of these cells to treat diabetes, but for years, attempts for preparing pancreatic extract to lower blood glucose were unsuccessful due to impurities and toxicities. Until Frederick Banting, a young orthopedic surgeon, he was, 30-year-old by that time, from Toronto, Canada, assisted by a medical student, Best, came with the idea their idea was isolating pancreatic islet extracts by ligating the pancreatic ducts of dogs and keeping these dogs alive until the acini degenerated, leaving the islets alone to be isolated and extracted. And the successful use of this pancreatic extract in 1922 to treat Margery. Margery was a pancreatectomized dog with an artificially induced diabetes. The success of its treatment with that extract marked a major breakthrough in medicine, of course. This is Bent and Best with Margery, their famous dog. Now, it was 11 a.m., April 23rd, in the year 1922, when a child called Leonard Thompson was given the first dose of insulin in the whole history. And in 5 p.m., he was given the second dose, with further 2 injections the following day. Glucosuria and ketonuria disappeared from Thompson's urine, and the boy markedly improved on subsequent days. There were 4 men who shared this historic great success and deserved the glory they achieved. Frederick Banting, we heard about him from every speaker and the honored previous speakers. Charles Best, James Collip, and John McLeod. Everyone has a definitive sort of work in the whole story, and they all worked in Toronto University. After intense struggle during that year, 1922, with several failures, they ended up by the end of the year by having a fairly stable preparation and was able to treat diabetes, and they called it insulin. This is Thompson. Before and after the injections of insulin, you can see the difference. In 1923, the next year, immediately, Banting and McLeod were awarded a well-deserved Nobel Prize in a very unique occasion of giving this top world honor to a discovery of that sort duration the same year. Usually, Nobel Prize waits for years and years until they are pretty sure that the invention of, or work is beneficial to humanity. But here, the case was exceptionally clear. Banting and McLeod announced it immediately, sharing their prizes with Best and Collip respectively. These are the pictures of those 4 scientists were appearing in everywhere in the media. Eli Lilly was the first company to begin producing insulin, and they managed to make more purification of the extract, leading to more potent animal insulin. In the year 1923, the University of Copenhagen received authorization for the University of Toronto, received authorization from the University of Toronto to bring insulin to Scandinavia. And insulin started to spread internationally. Because the insulin preparation required several injections per day, the prolongation of duration of insulin was desperately needed. In the 30s, in Denmark, they prolonged the action of insulin by adding protamine, and in Toronto, they prolonged the action by adding zinc, and that's how the discoveries led to the introduction of longer-acting animal insulin. These are the shape of insulin vials at the early stage, and this is the terrible syringe which was used to inject insulin to miserable patients. It needed to wait until 1978, very recently, for the first recombinant DNA human insulin was prepared, which opened the door for an unlimited production of of human insulin. And in 1982, Eli Lilly as well started to produce human insulin on large scale until we are to the present vials and syringes. The first pen actually was introduced in the year 1985, and the first insulin pump was used in the 70s before the pen. But it was very primitive actually and very big. It progressed very much with time until we are now approaching a closed loop artificial pancreas by using a very small set of insulin pump. Insulin analogs appeared later. Listro was the first short-acting insulin analog approved in 1996, and Aspart was approved in the year 2000. Currently, there are two basal analogs, again after short-acting. Glargine was approved in the year 2000, and Detimir approved in the year 2005. Let me finish up with this one slide about the future of insulin, just giving names of what's coming, what's in the pipelines. The next generation of insulin will be the smart glucose responsive insulins. I don't have time to go any further into these things. I'll just give names of these expected products. Continuous advances in the insulin delivery systems with new jet injectors, smart pens, patch pumps, and other needle-free devices for subcutaneous administration and weekly formulations. There are alternatives for the use of insulin. It's not for only for subcutaneous injections like we are using it now. There are advances in routes of insulin delivery, including pulmonary, nasal, buccal spray, oral insulin, capsules and tablets, and transdermal insulin. Most of these products, by the way, are currently in advanced stages of their production and may come to the market in the very near future. I have to stop here for the sake of time, thanking you all for your very kind attention. Thank you.
Thank you very much, Professor Adel, for a very nice, very well spoken, very well illustrated lecture in a short time. Thank you. Our next speaker for today is Dr. Ahmed Salman. Dr. Ahmed Salman is consultant physician in diabetes and endocrinology, acute general medicine, lead of multidisciplinary diabetic food team at Blackpool Victoria Hospital, lead in young person diabetes and transition clinics, department lead of clinical governance and mortality, IDF certificate expert trainer on conversion map, member of the ESAD, lifetime member of the National Association of Diabetes Education, Pakistan. He is going to talk about use of insulin in diabetes management, what is the best for the MENA region. Dr. Ahmed Salman, the floor is yours.
Thank you very much, Dr. Nadima, for kind invitation. Assalamu alaikum, and thank you very much for inviting me, Professor Naz and Dr. Shabina, for a kind invitation and kind introduction, and all the respected organizer, committee members, and the respected esteemed professionals. So I'm just going to share up with my slides and to take up with the topic on behalf of the insulin centenary. Nursing makes difference. So this is a brief introduction of myself, as Dr. Nadima has already introduced. Use of insulin in diabetes management, and it's a huge topic actually, and it's been a worth of talking about. In 15 minutes, it's really been hard to cover. What is the best solution for the MENA region? I'll try my best to give you some solutions which could be incorporated to make a best treatment plan in the MENA region. Sharing about the burden of diabetes, if I go through with the burden of diabetes, we already know, as Dr. Akhtar has already mentioned, that in Middle East and the North Africa and the African region has been high on the prevalence, and it's been reaching nearly next couple of years, in 20 years time, with nearly double the numbers as compared to the other areas of the IDF. Looking at the other part, Europe looks to be promising because it's been on 59 millions at the moment, and it's been soaring up to 15% comparing to the Middle East, which is going high at 96%. We all know that the huge tide is coming up, and we are facing a huge burden of diabetes over all the world globally, and particularly in the MENA region. I'm not going in detail with the numbers, but it's clearly mentioned that the age between 20 to 79, the numbers are soaring up. And in 2045, if we go like this, it's a projected figure go up to 687 million with a current of 426 million. Looking at the prevalence of the impaired glucose tolerance for the type 1 in the MENA region, it's been the same as like 20,800 on a yearly basis. I'm more concerned about the impaired glucose tolerance, in which we are progressing towards the type 2 florid occult diabetes, over diabetes, and there are huge numbers which is still been missing. Is 64 million in 2045 to the current of 35 million, which is nearly reaching to the double. Among the countries, if you look at Middle East, is been nearly hovering at 15 to 17%, apart from the Pakistan and Sudan, been sharing up the highest burden in the MENA, reaching up to 22% in Sudan and nearly 20% in Pakistan. Egypt to follow, and the rest of the Middle East countries been hovering at 15 to 17%. We all know that it's been a time to act, as among the 10 countries in diabetes, we are coming up on numbers in the higher list. And I'm afraid that Pakistan has been reaching up to third up on top of USA in 2045, which has really been alarming. What has been done so far, what should be done in future, these are the things which we all should think at the moment. Year-wise prevalence, if you look down from the 2000, there's a steady graph with a slight increase, and there's a stability between 2009 and 2017. And look at now 2017 and 19, the graph has been gone steeply high with 12.4% and total of 54.8 million people with diabetes. All these numbers are loudly saying that the things are not in a right direction. Poor glycemic control is associated with increased risk of micro and macrovascular complication, including the eyes, kidneys, erectile dysfunctions, neuropathy, foot disease, and the stroke and heart disease is with the peripheral vascular disease. We are at a verge of the time when we are losing our patients with a diabetes death. We are verge of the time when we are losing complicated patients in a younger group. We are at a time when we are being sewed up with huge burden of diabetes, which can't be neglected at all, keeping in mind that the burden is huge, but we can't get the solutions of it. I'm just thinking, giving you a think in mind that the long-term complications are the main contributor to the cost. It's like a kind of cost is draining in complications. When we have got the initial therapy and the patients develop acute complication, and it comes to the long-term complication, as per the brief model, it has been soared up to from the double the cost in the conservative management of a foot case in terms of the major amputation in US dollars. It's a brief idea to give you the mind that if we can't intervene in the middle or we can't intervene in the beginning, we will be at lost in making our patient in our community and the humanity from diabetes. Coming to the point of use of insulin, is nicely been shared by Professor Syed with the historical background. It's been Banting and Bess in 1921 has discovered insulin, which really been come up with a great idea, and the insulin production begins by Eli Lilly in 1922. It's been a time now almost 100 years. It's a century over to the insulin production, but still we need to ask ourselves how many of our patients are on insulin, how many of them are getting benefit of insulin, how many of them are using insulin. Despite of knowing that we start from animal model, then the human, then the analogs, and now we are talking about the weekly insulin, basal insulin. We are all talking about the analogs and everything. We are been advancing with the science, but what we have done so far for the solutions to combat these problems. With a respected honor to the Professor Samashera, who was a legend, and I'm blessed to be had some experience of sharing my things with Professor Samashera. Insulin should be started sooner than later, and insulin should be viewed as an essential therapeutic tool for achieving disease management goal. At an early stage of the disease, rather than as a sign of failure on the part of the physician or patient. What a saying by Professor Shera. It's been too late if you are late. In 2020, an ongoing dilemma is still how many of us knowing that the MENA region using insulin, how many of our patients, we don't have anything in the background. We don't have any homework done for it. Can we start insulin in type 2 from the day one? These are the questions which still not been answered despite of 100 years of diabetes. With the advent of the insulin, we move from the era of diabetic coma to the era of diabetic complications. A well-said Elliot Jocelyn in 1931, what has been done? The question arises again. I'm sharing up some of the evidence in a flash. Early and aggressive initiation, early insulin treatment, effective insulin therapy for beta cell function and glycemic control with a newly diagnosed, and a beta cell function preservation after 3-5 years. Knowing all the evidences, knowing all the things, is no way out to make solutions unless we act. Why should insulin be initiated? A very clear message. It's a progressive disease. It's a developmental disease. You are losing up your beta cell at the expense of the progress. Patients not come up with a plan. We have to make a plan and decision. Over the time, the oral agents will have to be declined. At the time of diagnosis, 50% of the beta cell has already gone. So we are being at the expense of remaining 50%. Shall we still wait for another 5-10 years to get progression to the complication, or shall we take an early decision? This is the question what I'm asking from myself, my other fraternity, and the people who have been looking after the diabetic patients. What are the fears and concerns? Coming to the point with the similar kind of fears and concerns. I've been hearing from my childhood, and now I've been a professional with the leading roles in the diabetic field. Lifestyle factors, the family and the relatives have their experience. There's a lack of improvement. Some of them are not really getting benefit, because if you are using at a last stage, when you have been near to die, what's going of improvement? You have to be on insulin earlier, the better. Myths about the insulin, it may be the last thing to add. It may be the last thing to start. False impressions, insulin causing complications. Cost of the insulin. I personally believe if we start insulin early, it may definitely come down on a cost rather than to give you a more cost as compared to the oral, which not be benefit more than 5 years. What are the social concerns? How can I travel? How can I make? All these things can be answered by the scientific modulation and by scientific prescription. But one thing can't be answered is a clinical inertia among the healthcare providers. What are the common concerns? The lack of decision, the time constraints, and they don't find the backup support. The educators not being prepared to give them time, or they are not being there. The dietitians not there. The workforce is being lacking, and we are in a significant lack in all over the world. And that's why we are not being find any solution so far, or we are lacking in solutions. I can say it's a lack of knowledge and experience of sharing up our knowledge into the implementation. Insulin counseling is the worth to ask for. Just dispelling the myths and the misconception by talking freely to the patient. Who are those? Who is going to the patient? Who is telling about the patient? I personally believe we as a role, as a leader, should have to take a responsibility to do the things. We as a dietitian and educators and nurses should have to take a responsibility to take the things. Patient will never come up to start me on insulin, knowing about the thing that the insulin has been there for 100 years. How many of us still put our patient on insulin? This is the question for everyone. Coming to the individualized counseling, if you come up with some of the positive side of the insulin use, you can provide them with a healthy knowledge of living without complication. You can provide them with the fear of injections, not the fear of injections, not the insulin, is basically the decision which you are lacking. You can give them example of celebrities. You can give them the examples to make sure that how people can live longer life by giving them the examples. The young males and females can live their normal reproductive life if they are normal with the glycemic control. They don't need to look for the doctor. They only need education. Who educate them? This is the question. Temporary start of the insulin would be a good choice in those who are not ready or mentally prepared, to give them a trial at an earlier step and to see that how they behave on it. If they work very good, they behave very positive, they themselves agree to take on insulin rather than to you have to take a decision on their behalf. Tell me I forget is as always the case. Teach me I remember. Involve me. This is what I believe, and we should believe that we should involve and learn and inform the patients. We need a power, we need an access, a learning, a thinking positive, and goals to be set in high morale. Unless we do that, patients are not going to be appreciated with our discussions. To prevent the complication and live a healthy life, what a saying. The goals of appropriate therapy for those who with diabetes should include a serious efforts to achieve level of blood glucose as close to those as in non-diabetic is feasible. We all know that we are running short of time, but still we are away. So I'll put on some possible solution if it's implemented or applicable in a due course of time to prevent the burden. What are those solutions? There's the IDF Global Voice of Diabetes. It's been embedded with lots of beautiful things. But for me, education would be the best one, which we can make a training change. The physical activities should be encouraged and promoted at a primary school and a secondary school level. The health topics should be embedded in the curriculum at an earlier step. Easy availability and accessibility to the healthy food to the children, training of family physician and the health providers, online certification of courses on diabetes educator, the workshops for nurses and health providers. Prepare yourself for local insulin therapy manual in your local languages. We don't want anything to be translated into English necessarily. We need local languages to be empowered to get a more trust to the patients. The other thing, who make it? Who can make a change? The policymakers and the programs. The nationwide diabetes registry should have to be established at once. Earlier, the better. From your local, start from your local work, go with the region, then international. Advisory board to decide on the fate of the managing diabetes, providing them with the national and regional level. The regional and national level of guidelines and pathways should have to be established. The guidelines implementation should be asked from the Ministry of Health by a resourceful people, the legislation authorities, and all should share their hands in making the diabetes as a kind of burden which are really being underlooked and not being taken as far. Low cost and effective strategies to educate and empower the staff at local and district level to facilitate primary level care, and the collaborative work which is still being lacking behind between the developed and the developing countries of region to facilitate the provision of good quality care, including financial support based on the governmentarial and the non-governmentarial organization. I must say, sorry for that, insulin is a remedy which is primarily the wise and not the foolish, be the patient or the doctor. It's nothing from anything, is a Jocelyn Elliott, a well-known person in 1923. And now, if I share with you with a leader, I think if we all are loyal, empowered, educate, dedicate, engage, and resilient, we can share with the barrier and solutions by giving a leader in between. In terms of resource, we have a roadmap. We should make an extension plan. We should have a strategies and solution. We should provide the opportunities in a good utilization with a backup of revenue generated on the government and non-governmentarial basis to set a care plan with the equality among the population to make a resource. If you live with this resource and leader, I would say we are no far to make a decision easy for the doctors to show up the compliance and the trust by the patient, and who can make it empowered is the nurses, which we are celebrating at this occasion. Nurses make the difference, who empowered and engaged and make your patients closer to your decision to educate and to make yourself more closer to your decision on the insulin treatment. Not least, but in the last, I would say, on the occasion of 14th November, we all united. We should all unite to defeat the cause, not for the purpose of ourselves or for our people, for the purpose of the humanity, for the purpose of the global improvement of this diabetes, for the purpose of the sake of the things, for the havoc of diabetes, which is coming ahead with a very, very high tide. And at that time, we may not be here, but people who are here, they will face the burden. So please do the things for your generation. Prevent them. People should be healthy life. The professionals should be involved. The policymakers should make a clear policy. The politicians should be passionate to make and implement their power and unified. And that's the ring which we believe in, and we as a diabetic fraternity should believe in future. I must say, By showing and demonstrating this diagram, I'm trying to express my gratitude that being a leader and the resource, we can make the barriers of diabetes into a solution to benefit our patient. And that's the end of the things. Otherwise, the rock is coming down and we all together being pulled down to the end when we have nothing left. Thank you very much.
Thank you, Dr. Salman, for an excellent presentation and for highlighting again the alarming problem of diabetes in our region and the possible solutions. Dear attendees, please don't forget to type your questions for Q&A session at the end of the scientific session. Now I would like to introduce Mrs. Pascal Naufal, who will be presenting diabetes education beyond insulin therapy. Mrs. Naufal is a holder of bachelor degree in nursing, a diabetes nurse educator certification from Leicester Diabetes Center, UK. She is certified in pump training. Mrs. Pascal has been a diabetes nurse educator at the Chronic Care Center, a specialized center for type 1 diabetes in Lebanon since 1998 till today. She is among a team of nurses taking care of 2,900 patients, and indeed, nurses make all the difference. Mrs. Naufal, the floor is yours.
Well, hello everyone, and thank you for the introduction. In the next 15 minutes, we will be discussing diabetes education beyond insulin therapy and how the nurses make the difference. We all know that self-management of diabetes is a challenging and complex process for patients physically, emotionally, socially, and intellectually, and that almost the majority of care in diabetes should be taken by people with diabetes and not by healthcare professionals. That's why patient education is the cornerstone in diabetes management, combined with support from family and peers. And nursing staff working at all levels are at the forefront in delivering this care and are key to promoting self-management skills. 4 critical time points have been defined by the American Diabetes Association as the need for diabetes self-management education and support. At diagnosis, of course, annually for assessment of education, nutrition, and emotional needs, when new complicating factors arise that influence self-management, when transitions in care occur, and more often if diabetes is not well controlled. So, what is the role of the diabetes specialist nurse? The list is too long, but I insisted on keeping it to emphasize on the multitasking role that the nurses assume when they are in charge of a person with diabetes. So, of course, the nurses have to educate patients, but it's not only about teaching and learning. It's more importantly about empowering the patient to use the informations for the self-management of his diabetes, and that will increase his knowledge and confidence. The education can be delivered through structured group education to people with diabetes and their carers, and of course, individually. The nurses instigate tests, analyze the results with the patients, and use them to optimize treatment interventions. They demonstrate expert knowledge of treatment and act as a resource for people with diabetes, their carers, and healthcare professionals. They perform an assessment of how lifestyle and pharmacological agents impact on glycemic control. Also, nurses assume telephone consultation, and that improves ongoing diabetes care. We at the center, the nurses are responsible of a hotline open 24 hours for emergency calls, and that has significantly reduced the rate of hospitalization for acute complications such as severe hypoglycemia and diabetes ketoacidosis. Also, during COVID-19, our nurses assumed phone call consultation, and 96% of our clients were satisfied of the service. The nurses also make more knowledge-based decisions and have more holistic views of patients. They provide emotional, psychological, and social support for both patients and their families, and most importantly, they assume the continuity of care. Also, nurses implement evidence-based practice in relation to prevention of and screening for type 2 diabetes. And that's not all. In a multidisciplinary team, the diabetes specialist nurse enhances knowledge across team members by providing staff with specific diabetes education. And the nurses reduce the time requirements on other clinical staff due effective and efficient management. And they are suggested to bridge communication gaps between clinical partners and patients. But let's not forget that nurses are part of a multidisciplinary team, and every member in the team is important in the success of the diabetes self-management education and support. That's why effective communication is key to working together amongst all team members. Respect, tolerance, and role definitions are important. Responsibilities should include open discussion regarding management, decision-making, problem-solving, and setting priorities with diabetes, and a collaborative approach to the pursuit of goals and outcomes are important. Most of the diabetes educators are registered nurses with additional diabetes education qualifications, but some persons from other disciplines can also assume that role if they acquire additional knowledge and skills. The International Diabetes Federation identifies the role of the diabetes educator as to enable people with diabetes to manage their health to the best of their ability, to allow them to make able choices and take actions based on informed judgment, and to enhance the quality of life of the person with diabetes. That's why implementing therapeutic education is fundamental to integrate patients in the prevention and control of non-communicable diseases. And as per the World Health Organization, therapeutic education should enable patients to acquire and maintain knowledge and skills that allow them to optimally manage their disease with their lives. So the first phase of the therapeutic education is assessing the diabetes clinical status and the related educational needs. The second phase involves developing an individualized plan that includes appropriate interventions and behavioral change processes. The third one is about finalizing the mutually agreed plan and implementing it accordingly. And finally, evaluation is critical since it reflects the success of the entire process and identifies if any changes to the plan are needed. So let's have an example. This graph is for one of our clients. Her name is Yara. She is 17 years old. She has diabetes since the age of 1 year and a half. And we can see clearly that Yara is doing great efforts in controlling her diabetes. Her estimated A1C is 4.6%, which is excellent. But if we look at the time in range, we find that 40% of her tests are in target, but 48% are below target, which means she is having frequent episodes of hypoglycemia. And in further investigation, we found out that Tiara is correcting her test every time she sees her test above 100 milligrams per deciliter because she is afraid of long-term complications. So what are the educational needs of Yara? She needs education about hypoglycemia prevention and treatment. She definitely needs to be reassured and educated about long-term complications and how to prevent. She needs education about insulin action, when to take and the right dosing, and the mutually agreed plan that was put between Yara and the team was to increase her glycemic target so she can feel again the symptoms of hypoglycemia, reduce her insulin to carb ratio, correct every 3 hours only if her test is above the target limit, which we put between 90 and 150 milligrams per deciliter. The follow-up was made over phone, and now Yara has only 15% of her test below target range and working to achieve better results. So what are the 6 stages of behavior change? The first one is the pre-contemplation stage. In that stage, the person is not intending to take action. Let's take, for example, an obese person who eats lots of junk food and is not aware of the problem. In the contemplation stage, that person is intending to change in the first 6 months. During the motivation phase, that person is intending to take action, so he is preparing a plan to lose weight. In the action phase, that person has made specific modifications in his lifestyle, so he started exercising and eating healthy. And during the maintenance phase, that person is trying to prevent relapse. So the diabetes educator and the patients have to identify the objectives and plannings. The goals have to be SMART, which means they have to be specific. Example, I am going for a walk. Measurable, I will walk for 30 minutes. Achievable, I can do that after work. Relevance, walking for 30 minutes will improve my glycemic control and my well-being. And time bound, I will walk 3 times a week, Monday, Wednesday, and Friday at 6. And remember, people's own decisions about behavior change coming from intrinsic motivation increase autonomy and the probability of a sustained change. So, what the person with diabetes need to learn about? All of these are core components of the education in diabetes. In addition to food care and prevention of long-term complications, but the educator should emphasize on the importance of testing, because without testing, the person with diabetes cannot feel if he is in a hypo or hyperglycemia state. He cannot know the right dosing of the medication, if it is safe to exercise, and how to calculate his carbs. Trying to control diabetes without testing is as if I was asking you to guess where this place is without showing you the whole image. In addition to testing, insulin therapy is a very important factor in controlling diabetes, since it is vital in managing the blood glucose levels in people with type 1 and in some people with type 2 diabetes. But for the treatment with insulin to be effective, it is necessary that the person with diabetes and the caregiver masters the insulin administration technique. That's why the role of the diabetes educator is cardinal in encouraging self-administration of insulin. Healthcare professionals still face some barriers to insulin initiation, and that will be discussed in details in the panel discussion, so stay with us. But in that case, the diabetes educator can enhance and maximize the patient engagement in self-care management, an understanding of the action of the medication, the comfort of the injection, safe and effective medication dosing, including when and how to take, site inspection and rotation. The educator should also assess the patient's skills and understanding by observing teachback and having the patient describe an action plan. Also, providers should choose positive, strength-based words and phrases that put people first, and patient performance should always be monitored. So the education has to be given in a person-centered care. So what is the person-centered care? Patient-centered care is the practice of caring for patients and their families. It includes listening to, informing and involving patients in their care, focusing care on the needs of the person rather than the needs of the service. The Institute of Medicine defines patient-centered care as providing care that is respectful of and responsive to individual patient preferences, needs, and values, and ensuring that patient values guide all clinical decisions. And we all agree that all patients deserve a high-quality health care. So the Picker's 8 principles of patient-centered care are respect for patients' preferences, coordination and integration of care, information and education, ensuring physical comfort and emotional support from the team and from family and friends, of course, ensuring the continuity and transition, and most importantly, the access to care. So what do our patients expect today? They expect us to ask what matters to them, not what is the matter with them, and nothing about me without me, patients being partner in sharing decision, in goal setting and planning. And remember, people will forget what you said, people will forget what you did, but they will never forget what you make them feel. That's why communication is of vital importance for exchange of information, keeping the language simple, being empathic, active and reflective listening to feedback. We have to value the person's active participation. Of course, we have to encourage and reinforce positivity, and that is very important. And we have to respect congruence between verbal and nonverbal communication. All of that can help the patient better engage in the conversation. So what are the outcomes of the diabetes self-management education and support? Improved diabetes knowledge and self-care behaviors, lower A1C and weight, improved quality of life and healthy coping, improved patient satisfaction, reduced all-cause mortality risk, length of stay in hospital and costs, and reduced acute and chronic complications. But diabetes specialist nurses still face some challenges. A clarification of the diabetes specialist nurse work is necessary in understanding and improving diabetes inpatient care, but there is no title protection or national accreditation framework for the diabetes specialist nurse. We have a wide variation in credentials and roles. Of course, more nurses are needed to support the increase in diabetes prevalence, need for continuing education, and certification for diabetes educators aren't available in many MENA countries. Just a little briefing about the Chronic Care Center in Lebanon. Our center is a non-profit organization. We take care of about 2,900 persons with type 1 diabetes. We run a knowledge assessment to assess the knowledge of our patients regarding their diabetes, and we found that 84% of them had a good knowledge in the different aspects of management of their diabetes, and that reflects positively on our mean HbA1c, which is 8.19%. But of course, we are still working on the gaps to achieve better results. And I want to end with a contention of Frances Welt Peabody's. The secret of the care of the patient is in caring for the patient. And I think the added value that the nurse has in diabetes education is caring. And caring is the reason of our success at the Chronic Care Center, which I'm very proud to be a member. I thank you for your active listening and for your participation, and hope you have a good continuity of the day and stay safe.
Thank you, Pascal, for this comprehensive talk and for your compassion in taking care of people with diabetes. Now I would like to introduce Dr. Sarah Sedakot, who will be presenting a very important topic, the role of communication skills to overcome therapeutic inertia. Dr. Sedakot is an empathy-driven diabetologist with a history of living with type 1 diabetes for more than 17 years. She is Deputy for Diabetes Education and Research in Gabric Diabetes Education Association in Iran, and experienced in the areas of training, technology, and innovative engagement management solution for people with diabetes. She is a reviewer for WHO Eastern Mediterranean Health Journal. Dr. Sedakot, we are eager to listen to you.
First of all, let me thank you, all the organizer and the speakers who had so many efforts to provide the opportunity for us to be together and talk about the diabetes and clinical inertia and insulin and all the etc. First of all, I'm going to introduce myself. As Michelle said, I'm a person living with type 1 diabetes, and it's been 18 years actually. And from the patient and the doctor's perspective, I I can feel what it means to have a collaboration with patients and to have a good communication with patients to tackle therapeutic inertia. As we know, our diabetes toolbox is growing every year, and we have so many diabetes medications nowadays. And but are we on the right track? Are we on the right track? This is the question that I'm asking myself. And when we see the trends in diabetes and in diabetes management, we can see that in the USA, the A1C more than 9% from 2006 to 2013 have been actually, it is going to grow, and the percent of people who are reaching the A1C less than 7 is declining. So this is the alarm that we should stop and think about the road that we are taking. We are growing our toolbox, but the patients aren't going to have a better diabetes management. So what's the problem? As all the speakers mentioned about therapeutic inertia, and I'm sure that you all know what is therapeutic inertia. It's the failure to advance therapy or de-intensify therapy when it's needed. And as the Newton cardinal we can see here, it's like running on a treadmill. It's like seeing a patient over and over again with no improvement. And we know from the trials that the conventional stepwise treatment approach that we are going to use to treat our patients is going to take 2.9 years for a patients from monotherapy to start to go on a dual combination therapy. So we know that the time to intensification is 3 months. So we should assess our therapy and assess the patient after 3 months. But the reality shows that we almost wait 2-3 years to add the second drug for the patient. And when it comes to insulin, it takes almost 6.7 years to put the patient on insulin. So we are not, this is not a good news. We know that this is going to put our patients at risk of macrovascular and microvascular complications. And we all know about the dysglycemic legacy and the years that we are losing with inertia is going to cost patient and the doctor and the healthcare system a lot. As we can see here, when we actually see a patient who is not reaching his A1C after 5.3 years, the risk of myocardial infarction, stroke, and heart failure and composite CVD events are increasing because of this glycemic legacy. So we have to find the solution to tackle this legacy and to tackle the therapeutic inertia. It's interesting to know that the ADA, American Diabetes Association, has a summit titled Overcoming Therapeutic Inertia, and they wanted people to name the one word that best describes the contributor of the therapeutic inertia. And as you can see in this picture, time is the one word that is most mentioned. And after that, cost, education, and fear is something that we should consider in our practice. Regarding the therapeutic inertia, we can put reasons into 3 categories: patient-related factors, physician-related factors, and healthcare system-related. So we are all in this together. It's not something that is just the patient's duty, or it's not just my blame as a physician or the healthcare system. We are all in this together, and we have to provide a holistic approach to overcome this therapeutic inertia. Rather than proactive care, underestimations of patients' need and inadequate physician-patient communication, they are the reason that I'm going to highlight because they are related to the communication skills. When we have a collaborative relation with our patients, we can set clear goals, we can start sharing decisions, so we can actually tackle these barriers. Regarding the patient-related barriers, as we can see here, poor communication between physician and patient is one of the most important barriers. And regarding the healthcare system and practice related barriers, we can see again poor communication between physician and staffs, including nurses and psychologists. It's an important barrier. So when we are, again in the ADA, when they ask people what is the top 3 words that best describes a potential solution to therapeutic inertia, education, time, and communication, they are all together. So the answer is easy. So the solution is to put them all together, to communicate in a collaborative way with our patients, to educate them, and to spend time with them. But the time is the most important, let's say, barrier for physician. And how can we address lack of time in our busy clinics and spending time with patients? Actually, it's a paradox. So when we see here, in order to insulin therapy, we know that fear of injection, negative appraisals of insulin, poor communication, side effects, and burdensome arrangements, they are all together to put the patient at the therapeutic inertia, and even us as clinicians. But the solutions are easy. The solutions are education or support from a psychologist and nurse-led management, because when we have these support system together, we can have our patient educated, we can spend more time because we have nurse-led management system. And when we are talking about decision cycle for patient-centered glycemic management, this cycle is so familiar. We are all using this cycle in our lectures, and this shows that how it is important to provide a patient-centered collaborative care. Patients should be part of the plan, not just the employee. They have to be involved in actually decision making. So we have to have a collaborative communication with patients to establish a plan, to set a plan that is patient-centered. And please avoid compliance and non-compliance and non-adherence, because they are dysfunctional concept in diabetes care. If we believe that collaborative communication is needed in diabetes, so non-compliance and non-adherence are dysfunctional concepts. And regarding the ADA, we can see that we need to improve our communication styles, to be empathizing, to use active listening techniques, open-ended question, reflective statement, and to summarize what the patient said. And empathy is a key aspect of patient-physician relationship. And this is an important the sentence that I write here. It's a quote, actually. The patient will never care how much we know until they know how much we care. So please have empathy with our patients, because the empathy can bring the patients on the board, and let patients describes their feelings and their perceptions about their own ability, self-efficacy, and self-management ability. So another important issue is our language. Our language matters. Language has a strong impact on perceptions and behaviors of our patients. And we should use a language that is person-first, strengths-based, empowering language that can improve our communication with patients, and it can enhance the motivation, health, and well-being of the person.
الشبكة طشت قاعدة تقطع.
Continue, Dr. Sarah.
Yeah. So the language matters, and we have some recommendations for language. We should use the neutral, non-judgmental, and factual-based language. We should use language that is free from stigma. We should use language that is strength-based, respectful, and inclusive, and imparts hope. And we should use the language that make the patients at the heart of that. We should use the language that makes the patient responsible for the diabetes care. So the person should be at the heart of the team, and she's the people with diabetes. He or she is the captain on the team. So our behavior matters. So we should ask people with diabetes about their fears, about their pains, and because they don't report it voluntarily. And let them talk and express their feelings, have the empathic communication, show empathy by addressing the patient's emotional concerns first, and explore worries and barriers to treatment, and acknowledge and reflect that the anxiety for the start of diabetes treatment or even intensification with new medication, especially in injection therapies, is normal, and we are all in this together. So we can go step by step, we can be together. And this is the art of medicine. If we are going to be clinicians who are loved by their patients, we should paint a beautiful picture of the communication with the patients. So we need the best communication ever with our patients to tackle therapeutic inertia. Thank you, everyone, to let me share my talk with you tonight, and I will be with you until the end of the topics.
Thank you, Dr. Sarah, for very nicely presented presentation, especially highlighting the role and the importance of communication and therapeutic inertia. Now the floor is open for questions. Dr. Michelle, you have the first question, I think.
So there was a question by an anonymous attendee. What's your opinion on training the HCPs and on carbs to insulin ratio? Won't this enhance their quality of education? Pascal, can you answer this?
Well, yes, carbs counting is very important in controlling diabetes, since it gives the person the freedom to choose the amount and the quality of food that he wants to eat, and it helps in preventing hypo and hyperglycemia.
Thank you, Pascal. I have a question to Dr. Adel Sayed. Dr. Adel, you presented, you talked something about a book that is talking about the history of insulin. Would you please tell us where we can find this book?
Well, thank you very much. Actually, this is an important, I consider one of the most important books, actually, because it covers the gap in the Arabic library regarding the issue of the insulin, because it is written in Arabic. Dr. Muhammad Mustah is a Syrian friend, now is working in Arbil in North Iraq. And he dedicated himself actually to write the book. He's very well written the language, the Arabic language written over there is very. So I have a suggestion book actually to the region. Dr. Jamal and Dr. Muhammad Sandid are here with us. I think that we have to pray for the region. I mean, to mark the celebration with the 100 years anniversary of insulin is to print this book. I can intervene, I mean, with the author, and we can make an agreement to print the book and then distribute it or to different member associations. I think that would be very good for people, because reading the book is a very, very interesting experience, actually.
It's a very nice idea, Dr. Adel. I hope Dr. Jamal can answer us after the webinar regarding this issue. Michelle, we have another question, I think, to Dr.
There is a question from Sekandar Rahul asking which insulin is ideal to be used in gestational diabetes and type 1 diabetes. Dr. Sarah or Dr. Salam, who would like to answer?
Salman.
No problem. I'll take that question here. In terms of the diabetes management in the pregnancy, it's been like a kind of something which we really been from the beginning knowing that the conventional insulins, which is insulatard or ectrapids, or you can say that the human insulin is being used in the previous past. And now the literature is being coming up with the new evidence that the analog insulin, including the levemir and even the clargine, would have been categorized as a category B, category C of the use of the insulin. So the thing's been broadened now, and we have got an experience as we move on with the analogs that it is very usual now that we continue the analogs. We don't need to stop them on any analogs. I don't still have anything data on the epidra or kind of homologs, but I personally believe that at some time we would be able to give an answer in more better shape since we get our experience on these insulins.
Thank you, Dr. Ahmad.
Dr. Nadima.
Yes.
Can I answer? Can I also answer this question?
Yes, please.
About use of insulin in pregnancy, the best insulin so far, the safety of which is established, is simply insulin R and insulin NPH. Detimer has also been used, but this is NPH and R, they are cheaper and they can be easily used by the patients. About the analog, the short-acting analogs are better for those who do not tolerate food and in whom the likelihood of hypoglycemia is more. So after they have a successful meal, they can have the analog. In case the women are vomiting or have too much of the nausea and are not able to tolerate food. So this is all I wanted to add to.
Thank you, Dr. Shabin. May I ask one question? As a diabetic nurse, what is the role of diabetic nurse during COVID-19?
Well, during COVID-19, we had the main concern at the center was to protect our patients since they have diabetes and they are at high risk. So we tried to give the service over the phone. So we had the consultations over the phone, and we did give the medical supplies and an outdoor access in our center to prevent the contamination in COVID-19 among our patients.
I would like to ask Dr. Ahmad Salman, how can we communicate together to make better care in our MENA region?
Oh, thank you for this extensive question. Actually, it's been like a kind of long story to cut short in a small answer. I have worked in MENA for 7 years time in Saudi Arabia, and the problem's been nearly the same. What has been going on over the last couple of years, it's been like kind of something, a poor engagement of the patients. And unfortunately, at sometimes the hurdles been overheaded to the solutions. And that's what's happening. And that's what I mentioned in my lecture, that unless we make some clear policy and standardize things on a basis of the primary and the secondary school level, where we need to look after our new generation, because whatever has been done is done. We are looking ahead to make our new generation healthy and to take the things from now onwards. because it's been of no use to regret on the things what has happened in the past. It has to be the time to look after ourselves and our new generation. So what are the proposed things to be done? First of all, as a part of the MENA, we should have all our local regional registry of the diabetic patients. So we know that how many of the diabetics every area. In broad aspects, we know our millions of diabetes, but in terms of our local registry, we should know how many of them are early complicated, how many of them are chronic complicated, how many of them are on insulin. So unless you establish anything on the diabetes registry, you won't be able to make any better solution. This is the first thing which we need to develop. The other thing is I mentioned that the development of the local languages curriculum and make up handouts and the publications and all that stuff in an easy material, in a patient-friendly material to provide them with all the knowledge what you need. And as a kind of the leader I mentioned on my slide, as a leader and resource, it's like a kind of some mnemonic, but in fact, it's the whole idea behind my talk, that if you have got a leaders who educate their decision, who put a decision in front of the patient and let them to understand the requirement and the use of the insulin at an earlier stage, there's no mean that patients are not going to agree on it. It's all how do you counsel them. If you counsel them in a positive way, if you counsel them with a positive incentive, if you come on with the things which really helps them to live longer, they would definitely accept. And the nurses have to play the role. And that's why my all emphasis that it's time to engage each other. It's time to remove the differences. We all are been running parallel to each other, but we are not integrated. In UK now, we started to look into the integrated transformation of the diabetes. The primary healthcare and the secondary healthcare is going to be integrated into the community, and I'm taking a part on that. So I'll go into say that if you look at your diabetic patient at an earlier stage when they really need you as a specialist, it makes a change. Or you see the patient at a last stage when everything gone out of the things, it's make a change. So we have to make a rational that what should be the best way to move forward by putting our heads together at a level of government and non-government, professional, non-professional, all, because diabetes is not a matter of my home or your home. It's a matter of the humanity which we are losing in a form of lives of genuine young people.
Thank you, Dr. Salman. We are running out of time. So for the sake of time, we'll take only the last question from the attendees. Do you think that restricting diet or specifically a no-carb diet will result in better glycemic control? What's your opinion in this regard? Won't this restriction on carbs will result in lack of energy to fuel the muscles and irregular bowel movement?
Okay, I'll take up if Professor Adil allow me to speak.
Yeah,
Professor
sure,
Adil.
absolutely.
Thank you very much.
Go ahead, please.
I think it's a matter of a low carb diet has been a kind of something which we really advise, but practically speaking, how many of them are compliant on it? It's a matter of the compliance. Advice is very easy. We can advise anything, but practically speaking, how many of us are following the advice? How many of us have been implementing the advice or educating the advice to the patients? The only rationale behind is that we have to know that what are the basic problems on behalf of diabetes is the obesity, which over the last 20 years been killing our diabetic patient. Now we are seeing the diabetes in the 20s and 30s. Before it's been like kind considered as a disease after 40s and 50s. But everything is been behaving like sedentary living, lack of physical activity, provision of the fast food and the junk. That's what I'm telling you. We need a legislative actions against non-healthy food. I remember the words from Professor Scherer. It's the mass weapons. The junk food are the mass weapons for diabetes. If you provide at the doorstep, if you provide them online deliveries, every doorstep you can get an access of these high carb food. How can you let the generation from a junior to come down on it? If you as a family member or the family head are been utilizing the or doing the same thing, how can you communicate to the generation to hold up? So what we do, we should preach the same. If we do the same, we will follow the same. So it's a matter of thinking that diet is some part of a component, but it's a part of the management at a stage when you are already diabetic. We are talking about something we prevent. Okay, in the prevention, there's a very big role of low carb diet, low caloric diet, physical activity. These things really need reminders. It's not like one time I go across and see the patient and after 8 months, I'll call them up. Have you tried the diet? No, it's not going to, anybody just apply on its own. Nobody is accepting it on one line. If it's so easy, why it's a global challenge then? It's a global challenge. In this time of world, I think we need perseverance, dedication, and professional strength to fight against the cause. It's not the diet, it's a multifactorial.
Thank you, Dr. Salman.
If you'd add one or two sentences.
Yes, I wanted to ask you that. I wanted Dr. Adel to add the last sentence as a doctor of WHO and IDF.
Absolutely, yeah.
Thank you very much indeed. The question was about no carb, and I'm astonished actually of no carb. No, there are no carb diets. No carb diet actually.
No
because well, carbohydrates are important. They are essential, and you have to take carbohydrates at the end of the day. But the issue is the equilibrium between the different components of it, rather than prevention of carbohydrate. And of course, nobody will say that. And I won't go through the details, but I would like to comment on that issue. No carb diet. No carb diet should never be healthy diet, and an unhealthy diet, because the fat will increase on the other hand. And so no, carbohydrate must be there, but in the proper percentage of the calorie content. Thank you.
I will like to add one thing. We are in the MENA region, not high income society. Most of us are low or middle income society, and we are carbohydrate eaters because it's cheaper.
We are, they are cheaper. You are absolutely correct. But meanwhile, we have to keep the percentage of the different. There is one thing. Vegetables in our area are relatively cheap, and in spite of we don't eat them sufficiently. Salad, for example, green salad. Just the contents of the green salad, potatoes, tomatoes, and everything. They are very cheap compared to the Western countries. For example, the green salad is the most expensive of it. So I mean, we don't make use of that opportunity, that advantage we have. We might be to stress on these issues actually regarding dieting.
So a balanced diet is the best one.
Yes. Thank you. I think we should move to our next session. Thank you, everybody. Thank the speakers and the audience and the organizer. Thank you, everybody.
Thank you.
Thank you all.
Thank you.
Thank you all the speakers, and we will leave you with the panel discussion that will be moderated by Professor Alton. Thank you.
موضوع اليوم العالمي للسكري لهالسنة بيسلط الضوء على أهمية دور الممرضين برعاية السكري.
بدي أشكر الممرضة سارة يلي ساعدتني اتخطى حاجز الخوف لما عملت أول إبرة أنسولين لبنتي نور.
أمي عندها السكري من النوع الثاني. شكر كتير كبير للممرض بول اللي ساعدني أهتم فيها بشكل أفضل.
ما بنسى أبداً الممرض يلي علمني كيف استعمل إبرة الأنسولين.
دورنا كأطباء بيتكامل مع دور الممرضين، خاصة بحسن إدارة السكري.
وبتذكر دايما الممرضة يلي علمتني أفحص السكر بالدم.
نعم، الممرضون يصنعون الفارق.
So, Dr. Altoum, this was a little interval between the two scientific sessions. So now the floor is over to you.
Ladies and gentlemen, friends and colleagues, very welcome to all of you on World Diabetes Day with dedicated theme of diabetes and the nurse, and also insulin centenary marking day or marking month. I'm very pleased to be the moderator of this session. So I take the opportunity to praise the organizers and the organizing committee of this webinar, and my special salute and my hat off to Professor Shabin for her dedication to make this event successful and fruitful. Before I start, I also take the liberty and opportunity to give my tribute to Samad Shira. Samad Shira is my co-mentor, where we started that in the mid-90s when he visited Sudan, visiting his colleague, Professor Bleu Mukhtar, and who with him and Professor Morsi Arab started the foundation of the Mena region. Since then, he's really my co-mentor, and he's always filling my tank with with advices and support. But let's see. So, I'm starting the first speaker of this panel group, Professor Hazim Abdulrazak. He's head of Iraqi Diabetes Association, and he's currently consultant internist of the Red Crescent Hospital Baghdad. When to speak, when to initiate insulin in type 2 diabetes. Please, Professor Hazim, the floor is yours.
Thank you very much, Mr. Chairman. In fact, the time is very, very tight, and I have to start immediately. As you know, that a commonly accepted view is that type 2 diabetes would develop when insulin secretion can no longer compensate for the metabolic disturbance. Also, the secretory capacity of beta cell of the pancreas would progressively decline. And so ultimately, the majority of type 2 diabetics, they will require insulin. As well, the improved longevity of diabetics will mean that more diabetics will require insulin at later stages of the disease, as well as the early diagnosis will extend the time of active treatment of diabetics. Now, the effect of use of insulin for type 2 diabetes, the effect of use of insulin for type 2 diabetes from the time of diagnosis, it has been evaluated in many clinical trials, notably the UK PDS. In the UK PDS, it has been shown that early and continued glucose control can reduce the microvascular complication, and in the long term, it would improve the cardiovascular prognosis. Also, this protection from microvascular and macrovascular complication has been shown or demonstrated as well in type 1 diabetics. Also, many studies have shown that the insulin therapy would improve the patient well-being, not necessarily with achieving a normal hemoglobin A1C. As well, many studies have shown that early insulin will put the beta cell at rest. So this would result that the remaining beta cell, they will recover their function. Also, it has been shown that the earlier insulin to be introduced in the course of diabetes, the less likely to cause hypoglycemia in the future. And as we know that the main adverse effect of insulin therapy are hypoglycemia and weight gain. And in fact, there was no important report of increased cancer risk with the long-term insulin therapy. Now, when to initiate insulin therapy? According to the IDA, insulin has to be initiated when after 3 months of triple therapy, hemoglobin A1C is not at target. Also, insulin therapy has to be initiated when the A1C is greater than 10, and when there is a severe hyperglycemia more than 300, and also when there are severe symptoms of hyperglycemia like polyuria, polydipsia, weight loss, ketosis or ketoacidosis, dehydration. Also when there is suspicion of what's called the LADA, that is the latent autoimmune diabetes of adults, or in case of the secondary pancreatic disease, like acute or chronic pancreatitis, or the rare cancer of the pancreas, or in case of patients who are taking glucocorticoids or immunosuppressant drugs, or during the acute management of acute medical conditions like acute myocardial infarction, severe infections, and so on. Now, what insulin has to be started? Usually the best insulin to start with in a type 2 diabetics are the basal insulin, simply because of its simplicity. It has to be given, it could be given only once daily, and also the titration of the dose is very simple for the patient. When basal insulin fails to achieve the target A1C in 3 months, then you have to add one preprandial rapid-acting insulin, better at the time of the biggest meal of the day, and this can be increased to 2 or even 3 preprandial doses, that is to say the basal bolus insulin. Or a GLP-1 receptor agonist, another option, a GLP-1 receptor agonist can be added to the basal insulin if A1C is not at target. Or premixed insulin can be added twice or 3 times daily, but in this case, you will lose flexibility, and also there will be no good coverage of basal insulin during night, and there will be more daytime hypoglycemia. With these regimes, oral agents has to be stopped if appropriate, with the exception of metformin, which usually can be continued together with basal insulin or with GLP-1 receptor agonist. While according to the AACE, if the target A1C is not met with basal insulin, then the
1 minute left.
Then the options available is to add GLP-1 receptor agonist, SGLT2 inhibitor, the P4 inhibitor, or prandial insulin in this order. Over basalization has to be avoided, and it's said to occur when the dose of basal insulin exceeds 0.5 unit per kg per day, or when fasting blood glucose down to less than 70. So in conclusion, the body of evidence supporting favorable balance of benefit to risk of insulin use continue to grow. The UKPDS shown both microvascular and cardiovascular benefit from insulin use, and the initiation of insulin is possible at various stages of the disease, and insulin may be the first pharmacotherapy during acute illnesses or severe metabolic decompensation. Thank you very much.
Thank you very much, Professor Hazim. Now our next speaker is Dr. Nizar Al-Basha. Dr. Nizar is born and worked for many years in Aleppo, Halab, and Syria. Now he's living in France. He's a former president of Syrian Endocrine Society. He's a former chairman of the IDF Mena region. Currently consultant in endocrine and diabetes department at Hotel Dior Hospital, Dior, France. He's going to speak about insulin availability during disaster and pandemic. Welcome, Dr. Nizar.
First of all, thank you all. Thank you, Dr. Shabin, for this nice symposium. And thank you, Dr. Muhammad Tom, for your introduction. Actually, I have been a former chairman of the region, but also I have been the chair of the IDF committee for diabetes in humanitarian settings during 2 years. This was very important because through this committee, we had a lot to do to help people on humanitarian setting, particularly on during disasters. Look for this slide. Now in 2019, we have more than 70 million people displaced worldwide. 26 are refugees, 45 internally displaced. And of course, a lot of them have diabetes. In 2016, there were more than 3 million displaced people with diabetes and more than 1 million persons living with diabetes in refugee situation. A huge number, of course. Today, the number is higher. When people are refugees or living in disaster situation, they have a lot of needs: medications, nutrition, monitoring diabetes, activity, physical activity, and food care, vision, and most importantly, mental health issues during the conflict, due to diabetes, and all these issues together. Taking care of people with diabetes during disaster, this is mean particularly people with diabetes, type 1. They need, of course, insulin, and this is an emergency case. In our region, Mena region, we had a committee working on this issue, and we already prepared a plan and program. This program was running during 3 years for refugees in Lebanon. And we followed more than 4,000 people with diabetes with free clinic, free insulin, free consultation, and free lab tests. And what is a very good program. Unfortunately, recently we have to stop this program to the problem of COVID and lack of funding from some international organization. With that, we have also worked with the insulin program, Life for a Child, Insulin for Life, and so on. And we got a lot of insulin to send to refugees in many parts of the world, particularly in Turkey for Syrian refugees, for Palestinians, and some of them for Lebanon. We didn't succeed to send to Yemen, where there is a lot of people who need insulin. But we still need to do a lot for monitoring glucose, dietary intake, and physical activity for these people. You shouldn't forget also these people need another medication for hypertension, dyslipidemia, and other related problems. So our committee was we visited the region and hosting country, Lebanon, Jordan, and Turkey. And we collect donations for these people, and we work with many organizations, Life for a Child, Insulin for Life, and we send many equipment and for hemoglobin AC1 and so on. And we try to help people with diabetes, particularly children with glucometers. We start even education during these campaigns in camps in low-income area for refugees. This work was done, but all our committee was included. A lot of people with Lebanese Diabetes Association, our colleagues from the region, Dr. Adel Sayed, and so other colleagues. But we still to focus on many challenges of these issues in the region. We are working with NGOs as IDF, but we couldn't succeed to work with WHO to help us in this issue. This is the most important issue. WHO prefer and continue to work with the Ministry of Health and not with the IDF until today. We try many times to do our best to involve them with our activity. It doesn't work. We work also with Life for a Child, Insulin for Life, to send some insulin for people with type 1 diabetes. But even with that, to send some insulin for Syrian refugees, Palestinian, and Yemen, there's still a lot of challenges and obstacles. For me, the most important one, that local regulation don't allow us to import and to provide insulin for refugees in camps and in other area of the region. So what is the most important issue? it's to us how to find the way to send insulin for this people. So I believe, yes, I have to conclude. There is a lot to do for people with diabetes, a refugee situation, and there is a lot of challenges to solve for that, to send them insulin. Thank you for listening.
Thank you very much, Dr. Nizar. And now we move to Ms. Eram Ghafoor. She will talk about diabetes education model in Pakistan, step by step. Eram Ghafoor is a consultant diabetes educator and public health specialist located in UK, and she's in Baga Institute of Diabetology and Endocrinology. She's a faculty secretary of National Association of Diabetes Educators of Pakistan. Please, Eram.
Thank you, sir. And Assalamu alaikum and hello, everyone. First of all, I would like to thank Dr. Shabinas and Dr. Altoum for providing me such a great opportunity. And I will start with how the concept of diabetes education get developed in Pakistan. This is because I'm going to talk about the model. So Bakai Institute of Diabetology and Endocrinology is a tertiary diabetes care center in Pakistan, which brings in the concept of diabetes education in our country. There was no diabetes education program on national level before 2008. In fact, we have started single one-to-one training of diabetes educators at BITE, but that was way back in 1996. We have officially started diploma in diabetes education in 2008. It took 3 years to get approval from the medical university because, again, the concept of diabetes education was new. Nobody knew anything about it, and it was not acceptable even to local endorsing bodies. It is 1 year course. The curriculum has been developed on the basis of IDF modules, which get revised regularly according to the. So I was telling about the curriculum. The curriculum has been developed on the basis of IDF modules, which gets revised regularly according to the current advances and evidence-based techniques. This diploma has 20 theory modules, a mandatory practical exposure on daily basis under the supervision of diabetes care team throughout the year. These diabetes educators also acquire exposure at tertiary care hospital to understand the actual meaning of multidisciplinary diabetes care team approach during the coursework. It is awarded by the medical university, which is unique of its kind in whole Pakistan. So far, we have trained more than 200 diabetes educators. The good job is that these diabetes educators are spreading the message through National Association of Diabetes Educators of Pakistan, which is NADAP, and that is a registered body by the government of Pakistan, and through Diabetic Association of Pakistan, DAP, through Diabetes Champions, which is a pan-Pakistan advocacy group, and through corporate sectors. These diabetes educators are also targeting and involving many celebrities from the different way of lives and community leaders to sensitize them and for the lifestyle modification, because we need to target primary prevention as well. Likewise, these educators are also inspiring schools, their managements, and college and universities, and even the practicing nurses. Multiple disciplines are being involved in diabetes care through these trained diabetes educators from our institute. Now we are taking the Nursing Council of Pakistan on board as the next step, because it is widely accepted that nurses are the existing working force that were underutilized and not being given due credit as a frontliners in diabetes care. So we are in process of designing 3 courses. a 6-week course from primary care nurses, a 1-year diploma for secondary care nurses, and 2-year degree program for tertiary care nurses as advanced nurse practitioners to equip them for the focused diabetes care management at all levels and to standardize the diabetes care in Pakistan. We are taking small steps but the concrete one, and we look forward for the diabetes-free Pakistan. Thank you for your kind attention.
Thank you very much. Really, this is done in a very short, good time era. And we continue. And our next speaker is Hormuz Kai Khanzada. He's a co-founder and CEO of Gabric Diabetes Education Association. He has been living with type 2 with type 1 diabetes since the age of 14. So, and he's a social entrepreneur and founder of the Gabric. So, welcome.
Hello, everyone. Good evening to the participants of the Eastern countries and good afternoon to the participants of the Western countries. I want to talk about the economic sanction and the consequences of supply of diabetes supply and pharmaceuticals for people with diabetes. We all know that our region is one of the most unstable geopolitics in terms of political turmoils and war. This is quite sad, and unfortunately, it will affect the care of people living with diabetes, and their life has been impacted significantly. I want to talk about the economic sanction, or sometimes it's called economic warfare. So these are kind of tools used by politicians to put pressure on the countries and try to punish them, or whatever they call it, try to persuade them to change their behavior. But how it looks like, it's normally defined by refusal of selling some goods to the countries and by making some trade restrictions. Some countries in our region has been affected. Iraq, Sudan, Libya, Iran are few examples of countries in our region that has been affected by this. More importantly, about Iran, we see a very important shortage we see, and it is because of the unilateral economic sanction imposed by US government during the Trump administration in recent years. And we are suffering hugely. We see the shortage of insulin, we see the shortage of blood glucose test supplies, and we as advocacy association need to raise the voice and talk about it in such communities. Our call center every day receives many calls from type 1 patients, from parents of children with diabetes. They are worried about not having test supply to test the blood sugar during the midnight, or even sometimes they cannot find the insulin they used to use, and they have to switch to other insulin, or they cannot even find the insulin. So in theory, the sanctions are not supposed to cover medicine and pharmaceuticals, but in theory, it will affect that. And I think we as NGOs, as an advocacy bodies, need to raise the voice, need to talk to WHO, need to talk to IDF. And I appreciate Professor Adel Sayed, Professor Akhtar Hossein, and also IDF to take this issue seriously and support Iranian, and are looking for different alternatives we can get out of this crisis. And finally, I want to say, if Banting was alive, what would he think of us about his legacy? So he discovered insulin 100 years ago, and his idea was that that could be an universal drug available for all the people. But now he see that because of the politicians, this product is not available for many people. I think he would not be that much happy, and he would criticize the politicians a lot. Thank you very much.
Thank you very much, Hormuz. You are really saving some time. You are giving the point, and it is very well convincing. And we move to the speaker, Mrs. Khitma Muhammad. She's going to speak about the role of nurses in unlocking barriers in insulin initiation and titration. Khitma Muhammad is a senior registered nurse, and she is working in the police hospital, so she is holding a rank of colonel. She is the head of Department of Diabetes Education. Please, Khitma.
Good day, everyone. Thank you, Ms. Shabin, and thank you, Prof. Muhammad Ali Tom, for giving me this chance to talk about our role in unlocking barriers in insulin initiation and titration. Although the insulin, the initiation of insulin has been improved for the last decade, but still there are some patients who still have the fear of injection and of the painless of the pain of the needles and inability to inject themselves and fear of inability to do it in a right way and resistant to make a frequent home glucose monitoring and fear of body weight. And the wrong beliefs and once on insulin, they think that once they start insulin, they cannot be stopped, as if it is an addiction. And insulin can cause blindness and attack and a heart attack and amputation. And they have this wrong belief because many doctors, they start the patient late, or the patient came late with already complication. And then when they start him on insulin, the complication was already started, and they think that this complication, blindness or heart attack, is from the insulin. The patient need quality time. We need to give patient quality time, and their patient and their families, and we describe and empower insulin injection therapy, and we educate how to detect hypoglycemia and how to manage and how to adjust insulin dose. This is their fear about the hypoglycemia. So the patient should be empowered and encouraged to know the hypoglycemia. Hypoglycemia will start with signs and symptoms, and the patient, he should know early this sign and symptom to prevent the occurrence of the opposite episodes of hypoglycemia. We address the patient fears and his wrong belief and his anxiety, and we address insulin, and they are still our patient. They will say that we don't have fridge and we don't know how to store insulin and where to keep it, and the insulin, and we cannot take insulin when we go out, or we cannot take insulin with our work. The other slide, and this is what they think of insulin. Many patients, they have the experience from the others. If they know somebody who had complication with insulin, like the hypertrophies, they will be resistant to take the insulin. And this patient, because they are taking the insulin in one place, they have this hypertrophy, and they still take in the same place because it is painless, and they take it. But when we address all this barrier and we try to solve it, like what is in our picture, we just train them how to inject the insulin in a simple way, in a simple, we sit relax with the patient, give him a time, try to show him the injection. The needle is so fine and small, and he can do it himself, even he's more than 70 years old. And we train them, and we just do it with them, and they already have their injection. And even the children, the children under the age of 7 or more, they can do their own injection. And we address all these fears. And for the storage of insulin in Sudan, many of them, they don't have fridge and they don't know where to store it. And they're afraid that insulin is going to be not affected because they don't have fridge. Actually, the insulin can stay 37 degrees at room temperature, and they can keep it in the place where they sit. And even they sit in a desert, they can keep the insulin and the raw insulin and put it under the, we have in Sudan clay pots with sackcloth. All these things can be used to store insulin if they don't have fridge. All these barriers addressed. For the titration of insulin, we just empower patients to correlate the insulin dose with their meal, their activities, and they do home glucose monitoring, and they can manage their own insulin dose themselves according to the episodes of hypo and hyperglycemia. And thank you very much. And again, I'm going to thank Dr. Muhammad Ali for his great support for the educator in Sudan. Thank you very much.
Thank you very much for keeping the time. And now we move to Professor Muhammad Zaman Sheikh. He's going to speak about resistance in prescribing insulin among healthcare providers. Professor Zaman is a consultant endocrinologist, diabetologist at Karachi. He serves in Dow University Health Science at Karachi as professor of medicine and head of the department. He is at present working as a professor and head department of medicine at CLC, the College of Medical Science in Karachi. Welcome, Professor Zaman.
Thank you very much. I'm grateful to Professor Shabinas for giving me a chance to talk for a few minutes in this very important topic, and I'm grateful to Professor Eltam for conducting this session very nicely. And now insulin inertia is part of medical inertia. We know that beta cells in normal person and in type 2 diabetes, they are quite different due to apoptosis. So about 50% of patients with type 2 diabetes, eventually they need insulin after roughly around 10 years because of death of beta cell mass, and they need insulin to prevent further complications. So otherwise they will develop micro and macrovascular complications. Now in this study, down there, blue line, this shows that continued use of oral hypoglycemic agents in spite of the presence of hyperglycemia may lead to so many complications as compared with insulin therapy, upper two lines, when we start timely insulin early. So this is a conservative approach to management of type 2 diabetes, means that treatment targets are either not reached or not maintained, and HbA1c remain high if we delay in starting insulin, versus this approach in which we start insulin early to prevent complication, and HbA1c is controlled very well if we start insulin early. Okay, this survey shows that primary care physician as well as specialists, more than 70% they say that I would treat my patients more aggressively if there was no concern about hypo, especially nocturnal hypo, because they are afraid that patient may go to bed at night alive, and people may find their dead body in the morning because of nocturnal hypoglycemia. So due to this fear, hypoglycemia is a risk factor for later hyperglycemic related complications. There are so many other barriers besides hypo, like the lack of education from healthcare provider, fear of obesity, complex regimen, 3-4 injections in a day, and they have to change insulin so many times a day according to so many blood sugar testing. And risk of comorbidities, especially in kidney failure and recently my hypoglycemia, may be more dangerous. So this is another fear. They are afraid of intensifying insulin. Sometimes resource issues like refrigeration is not there, especially in villages. In this study, this bar is physician perception. This is patient perception. So physicians are even more afraid of starting insulin than patients in this survey. So there are different approaches to prevent these barriers, especially education, counseling, and we may use those insulins which are easily administered, like once in a day. Nowadays, so many insulin, they are available in which ultra short acting along with basal insulin, 2-in-1, single shot in 24 hours, or even 2 drugs in 1 shot in 24 hours, GLP-1 receptor agonist along with basal insulin, and single shot is compliance will be easier. So these regimens may be started along with education. Okay, so conclusion, be aggressive. Medical inertia, especially for insulin, is not good. Rather, this can be very dangerous. Thank you.
Thank you very much, Professor Zaman. It was my concern that the time will not allow us, and everybody was really put into the time allotted for. So it gives us time for discussion and for questions as well. So this is actually this session of the panel discussion. It was really meant or planned to be the streamline of the previous scientific session, which is focusing also on education, nurses' role, and nurses' an insulin regimen, and insulin availability in special situations. Was the panelists very well demonstrated and clearly the importance of education in diabetes management, the vital role of nurses in this area. Challenges of insulin availability in special situation need to be assessed and mitigated, especially in situation. I have a raising hand from Zaid Atif in Yemen. He's calling for assistance that they have insulin shortage, and he's claiming that nobody can do that other than WHO. I think NGOs have got also a role forward. Dr. Nizar has mentioned that there is some challenges in that the local authorities obstructing. So probably he might give us some information in what way. I mean, I thought that the local authority should facilitate, not obstruct. That may be one question to do. Nizar to explain further. Maybe a couple of questions came first for Dr. Hazim, Ahmed Abu Hadawa, and from Muhammad Al-Salah. Muhammad is asking about how early should we start insulin for patients for mixed cardiovascular risk, such as smoking, dyslipidemia, despite hemoglobin A1C is less than 10. And if I proceed to the other question, so that Dr. Hazim can ask the question after Nizar. And Dr. Ahmed Al-Halawa from the Palestinian Association is that he's asking, and that the question is that what do we mean by early start of insulin? Does early means immediately after the diagnosis of diabetes, or as early as possible when hemoglobin A1C is no more under the control? The question also could be addressed to other speakers if they want to address on that, and we proceed. Maybe Professor Zaman would also make a comment, and then probably this issue we'd like to focus more on the MENA region, what to do regarding the education, because some question also came about how can we do diabetes education accreditation, and is there some question also that I might address about the diabetes school. Maybe Iram, could that be a foundation for diabetes school for the MENA region? Yes, please start, Dr. Hazim.
Yes, thank you very much. For the first question about patient with cardiovascular risk, possibly with the new drugs, with the newly introduced drugs, especially the SGLT2 inhibitor, and the GLP-1 receptor agonist. Possibly, these drugs have to be introduced before we added insulin. Because you know of the proved cardiovascular benefit of these two groups of drugs. And the second thing about Abu Halawa question, I think he's asking about the introduction of insulin from the time of diagnosis of the disease of diabetes. Some patients with severe hyperglycemia, they have what's called glucotoxicity and lipotoxicity. And these toxicities, sometimes they are difficult to be overcome with oral agents, so that insulin therapy has to be introduced initially for a short period of time, maybe a course of a few weeks, and after control of the hyperglycemia, then the patient can be returned back to oral therapy.
Sorry, can I, hello?
Yes, please, Professor Zaman, yes.
I totally agree with Professor Hazem. And I may add that if sugar is not controlled with GLP-1 receptor agonist or SGLT2-1 alone, then we may add insulin in type 2 diabetic patient, and we know that there is no upper limit of insulin dose. So we go on adding insulin even along with these two drugs when sugar is not controlled and there is cardiovascular problem.
Maybe the question would be to the diabetes.
Dr. Ultum, can I take a question here?
Yes, sure.
Thank you for being. It's been an excellent panel presentation. We're well timed. I'm just wondering that we are talking about the insulin part of the discussion, although we know that. Thank you very much. I know that now we have been advancing on the scientific side of GLPs and SGLT2 inhibitors. So it's been really in good practice with us. I'm a fan of SGLT2 and GLP-1, and I'm using it in my patients where we don't have issues with the cost at the moment. What we are trying to find out, to remove the rock of the community with the basics needs. We are talking about something of a low poverty area. We are talking about the accessibility issues. We are talking about the access of the healthcare. We are talking about the availability of the insulin in those areas where we can't get it. So I think these are all agents which can be tried at a part of some cardiovascular benefit as a scientific data. But we are talking about the massive population of humanity which are not yet being able to get something on oral treatment or early insulin therapy. So what my understanding from the message of this webinar, that we should make out the strategies to get everybody with insulin, at least at the earlier step, so that at least they can't go out of the disease complications. They should be safe from the disease complication. If they afford it, if we can provide them with the better options and the better choices, we can go with SGLT2, we can go with GLPs, but at the ground level reality, we are far behind on the initiation of insulin with the clinical inertia among the healthcare providers, as what we highlighted. So the thing is that how do we develop this model? I think one of the latest in my knowledge is that the Pakistan has established an insulin registry, and Professor Yaqub Hamdani has been looking after for Insulin My Life, and he's been spreading out the message. Professor Zaman Sheikh has been involved in many of the activities across the country. I think this is the right time to take these legendary people to come across the board and take a decision on the ground realities what we are facing. GLPs and SGLT2s is a scientific part of the discussion in ADAs and ESDs, but it's not been for the MENA region who is soaring out with the development of diabetes by 100%. How can you let these community with the mass effect of GLP and SGLT2 if they are not getting an access to the regular food? Dr. Nadima has been saying that they are low with the carb diets because they're poverty. How can you combat this poverty? So we need to establish the realistic plan. We are scientific people, but on the other side, we are humanly understandable with the realistic approach of the things which needs at a ground level. That's the message what I think it should be conveyed to all over the audience. in terms of early initiation of insulin is always be required rather than to go to the inertia, either the medical or the clinical inertia.
Good message, Dr. Ahmed. Yes, Professor
a lot of
Jamal.
hands up.
Okay.
Yes.
Yes,
Can I
boss.
comment,
Maybe
Mohammed?
Dr.
Yes,
Adil.
boss.
Dr. Adil. Yes, please.
No,
Well, this is a sensitive and very important issue. I totally agree with Ahmed Salman. Actually, we are living in a poor area. So to start with, we have to learn our physicians, especially young physicians. Young physicians are coming under enormous pressure from the pharma industry to prescribe these expensive drugs. Most of the medical care in our area are based on out-of-pocket basis. So people are paying for their treatment. So we have to learn our young physicians how to tightly control diabetes, that's number one, how to make good dieting, how to stop smoking, how to practice medical exercise, physical exercise. I mean, we have a lot of things to start with after failure of everything. And if the patient can afford, we can then think of these expensive drugs. But don't start with that. I mean, this is an important issue. The WHO had guidelines published in the Annals of Internal Medicine in the year 17. I was part of that. And the consensus of the ADA and ESD are putting, I mean, a special section for the situation when the cost is an important issue, and the cost is a very important issue in every part of our region. So we have to learn about that. Thank you, Ahmed, for
Yes,
that.
I think to make discussion more interactive, we have to discuss more in education and nurses, the role of education and nursing. Maybe I could ask Iram. I mean, she displayed a very nice experience of Pakistan, and at the MENA region, there is a planning now for diabetes school. Yes, my friend Misbah is not here. He is head of the committee. And would that, the question, would this experience of Iran could be transcribed to be brought up to be like a model for MENA diabetes school? I mean, that could be the question for Iran and for the panel and to make it more interactive. Another question that people would like to discuss around is regarding the nursing. How far they go in the medical legal activities? Can they initiate or not initiate? Probably titrate insulin. Can they? Because insulin titration really is a burden and a heavy burden on the medical nurse. Some of them they don't have the experience. Many of them in primary care. If you have good diabetes educator, very good nurses, specialist trainers, and so on, they could help a lot in insulin titration. How far in different countries is this practice? So if we make this session more interactive beside the subject, so it will, we have maybe 3 minutes if the organizers allow us to discuss this. Nurses or education, maybe it's a school or school in general. Adil, you're smiling.
Right. Thank you.
Okay,
Thank
Iram is speaking.
Okay,
Yes,
okay,
please, sorry.
Okay, thank you. Aram, go ahead, please.
So, sir, please go ahead. Dr. Adil, please.
No, thank you. I mean, I would just to give a hint about the communications we are currently doing, Jamal and I, with the EMRO office, with the WHO. Today, we were finishing the negotiations about having an initiative regarding the nurses in our region. Today, just a couple of hours before starting that meeting, we were in a meeting, Jamal Belkhadir and myself, regarding an initiative for the nurses in the East Mediterranean regions, as it is called by the WHO, and MENA region as it's called by the IDF. And that initiative, we will start with a webinar on the 30th of November. You all are invited to attend that and to see it. It's between the EMRO office, WHO, the MENA region, IDF, and the ICN, the International Organization of Nursing. These three will meet on the 30th of November to start a long-term initiative. Maybe it is planned to be for a couple of years, just to study the gaps and agree what to do. So the issue of nursing now is right in the center of the MENA region. And I hope during the coming few months we'll have a lot of initiatives regarding that. Thank you.
Thank you, sir. Sir, I think the first thing which we need is that we should have some standard, some guidelines, a course because if you see the nurses in MENA region, they are not even allowed to titrate the insulin. They are not even allowed to even change the insulin. But if you compare that from the UK and US, that is totally different scenario. They can titrate insulin. I mean, legally, I am not allowed to titrate insulin in MENA region. Most of the countries in MENA region, nurses are not allowed to do this. So first of all, I think if we want to improve the diabetes education model in MENA region, we should have a guideline, a course designed by all the experienced people from the MENA region to decide that what should be the step-by-step training for them and how we are different from the other regions and what our needs are. So that should be according to that, and that's how we can proceed towards a better nursing care for the diabetes education.
Do you have any comment?
Can I comment, Dr. Muhammad Ali?
Yes, do nurses in Sudan do titration of insulin?
Yes. We do that. We do the titration of insulin, and we empower the patient to titrate his own medication. As diabetes is self-management, we encourage the patient to take care of himself. From my experience, many patients, they just start insulin. They took the insulin from their families, from their neighbors, from one who told them that this insulin will improve your health, and they just start. If he comes to the doctor and they ask them, what dose of insulin you take? He might say 30-20. And when they come to us, who start the insulin with you? He says that I took the insulin with my neighbor and I'm doing it good. That's why, and I think the nurses, qualified nurses, they can do the titration of the insulin. As the patient himself,
thank you.
The patient,
Thank you.
The patient himself can titrate, because the patient himself can stop insulin if he had hypoglycemia. Severe hypoglycemia, he can stop his insulin, but the nurse can show him, don't stop. Please cut the insulin slowly to 2 units, and then make a glucose one.
This is part of the self-management education, self-management support, which is usually done mainly by the diabetes educator, and probably they are educators at the healthcare professional or diabetes nurses. So we acknowledge that, and we should really support this so that we work as a team with medical professionals. I think we come to the end of this panel. We thank the organizing committee, and we thank you, all of you, and thank you very much.
Thank you very much,
everyone. Thank you, everybody, for being with us. Now this is the time to say thanks. First of all, I'll be thankful to all the speakers panelists, and moderators, not only for today's talk, but for sparing their time for weekly Zoom meetings for the last 2 months in preparation of this event. And
thank you,
my
Mrs.
special
Shabin.
thanks
Masalama.
yeah, thank you very much. My special
See
thanks
you
to
again.
Professor Jamal, Nadima, Michelle, and Professor Altoum for coordination, guidance, and thank you, Iram, and also to Manal for their coordination, and Iram for the preparation of slide layout. That was very helpful, in fact.
Thank you.
Thank you very much. My special thanks to Extensia Diabetes Care for their sponsorship of this program. And let me tell you that each person who was informed and educated from these webinars that resulted in the improvement of the treatment of the patient suffering from diabetes, the blessings and reward would go to the presenters and to the sponsors equally. So a great task, in fact, and I'm very, very thankful on behalf of Insulin Centenary Working Group to Extensia Diabetes Care. Last but not the least, my gratitude to Amber event organizers, especially Rafat and Amar Hussain, for their coordination, quick responses, and attention to minute details, and their readiness to incorporate changes into the program without any hesitation. So I asked them a number of times, change the things a number of times, but every time I found them very responsive, and they readily accepted whatever was requested to them. So in the end, thank you, Rafat, thank you, Amar Hussain, and thank you, Amber Event Organization, for running this show absolutely smoothly and uninterrupted, and for being with us for almost 2.5 months while we were preparing this Insulin Centenary program and World Diabetes Day program. Special thanks to Dr. Salman, Dr. Professor Adil Al-Sayed, Dr. Salman, Pascal, and Sarah Sadiqat for their excellent scientific presentations. I'm thankful to Dr. Altoum for conducting this session very nicely, Dr. Altoum. It was a difficult session in the sense that the time allocated was too little, and you, in fact, coordinated and controlled the session very well. And thanks to all the speakers for abiding by the time, especially to Professor Hazim, Professor Dr. Nizar, Iram Ghafoor, Hormoz. Hormoz, your talk was really nice and extempore. Khitma and Professor Zaman Sheikh. Special thanks to Professor Zaman Sheikh for his agreeing to participate in the program, because at the last moment, the sad thing that Dr. Sulaf was suffering from COVID, and she was very symptomatic. We wish her good health and early recovery. Dr. Altoum, please convey our message to her, and we'll try to send her good wishes as well. So thank you, everybody, and thanks once again to Extensia and Amber event organizers.
موضوع اليوم العالمي للسكري لهالسنة بيسلط الضوء على أهمية دور الممرضين برعاية السكري.
بدي أشكر الممرضة سارة يلي ساعدتني اتخطى حاجز الخوف لما عملت أول إبرة أنسولين لبنتي نور.
أمي عندها السكري من النوع الثاني. شكر كتير كبير للممرض بول اللي ساعدني أهتم فيها بشكل أفضل.
ما بنسى أبداً الممرض يلي علمني كيف استعمل إبرة الأنسولين.
دورنا كأطباء بيتكامل مع دور الممرضين، خاصة بحسن إدارة السكري.
وبتذكر دايماً الممرضة يلي علمتني أفحص السكر بالدم.
نعم، الممرضون يصنعون الفارق.